Human Services will now come to order. The clerk will call the roll.
Chair Frank?
Here.
Vice Chair Rose?
Here.
Representative Click?
Here.
Representative Shaheen? Representative Ramos? Representative Noble?
Here.
Representative Campos? Representative Pohl?
Here.
And Representative Manuel.
Quorum is present. Members, we're going to go ahead, if I can find my place in my script. There we go. We're going to go ahead and hear one of Chair Rose's bills, and then we'll vote out once we get the rest of the members here. Chair lays out House Bill 2802 and recognizes Vice Chair Rose to explain her bill.
Thank you, Mr. Chairman. Members, studies have shown that more than 9 million Texans have no access to broadband internet connection. Of these households without broadband internet access, 64% are families of color. These disparities are not present in cell phone ownership, with 97% of Americans owning a cell phone of some kind. 15% of Americans depend on their cell phone for access to the internet, with 27% of them making less than $30,000 a year, qualifying them for Medicaid in Texas. Currently, MCOs and health plan providers are only able to call or email reminders to their beneficiaries on an opt-in basis, which this is a cleanup bill. As y'all know, last session I passed this bill, but we're having to clean it up a little bit. This limits the contact health plans can have with their members. In 2019, Louisiana allowed MCOs and health plan providers to call, text, and their beneficiaries on an opt-in out basis, led to a 10% increase in Medicaid renewals, according to a report by Beck Center. So HB 2802 moves Texas to an opt-out state while retaining all the protections we have put in place in the last several sessions to protect members from unwanted communications. And with that, Mr. Chairman, I reserve the right to close.
Okay. All right. Members, Chair recognizes Representative Campos is present. Members, anybody have any questions for Vice Chair Rose? All right. And we do have one person wishing to testify, so we will reserve your right to close. And Chair calls Jessica Lynch, Texas Association of Health Plans, for the bill. Ms. Lynch, do we have you correct there? Jessica Lynch, Texas Association of Health Plans, for the bill.
Good afternoon. My name is Jessica Lynch. I'm with the Texas Association of Health Plans, and THP supports HB 2802. In this capacity, I serve as the Director of Policy and Medicaid Operations for THP. HB 2802 will allow Medicaid members to easily receive important health-related updates, including now eligibility and enrollment updates, via text and email from their health plans. Specifically, this bill does 4 things. It ensures that members can receive eligibility and enrollment information from their MCO in the same way that they currently receive other information like appointment reminders. And this change, like Representative Rose alluded to, is being done to align with FCC guidance that came out in January of this year.
You said FCC?
FCC guidance, correct. It also simplifies the preferred, okay. It also simplifies the preferred method of contact on the application. It adds consent protections so that members are informed that they can unsubscribe or change their contact preferences at any time. And then finally, it ensures that MCOs do not have to unnecessarily report their members' preferred contact information that the MCOs collect themselves directly from the member. So why are we doing all of this? Representative Rose, at the start of her testimony, provided some excellent stats on the effectiveness of texting with our Medicaid members. So let's specifically talk about how this has worked in other states. At least 21 states already allow texting with implied consent with an option to unsubscribe. When Montana began sending texts and emails to update member addresses for returned mail, individuals who received a text were 40% more likely to update their entire contact information. And about 25 of those members responded to update their mailing addresses specifically. In Tennessee, one Medicaid MCO implemented its text message program and connected with more than 60% of their members and found that mobile reminders had been 50% more effective as a result. Another MCO uses text messages for expecting mothers who receive a series of messages pertaining to healthy eating habits, what to expect during prenatal checkups, and suggestions for staying active. Bring that home to Texas. Plans can text members now with consent. That is not changing. The goal is to make this more effective and easier for members to sign up. So on the last page of my written testimony is the current preferred method of consent on the Medicaid application. Somehow, we have turned this into a two-step process. Members have to both check a box and provide their contact information. Our goal is to simplify this process so that the preferred method of consent is still required, but it becomes a one-step process. I'll stop now if there are any questions.
Okay. Members, any questions? I was trying to figure out why, because I mean, it seems like good practice, of course. But y'all really don't have the ability to do this now?
We can text now. It is the kind of the ineffectiveness of what has resulted from the last several sessions where we now have a situation on the Medicaid application where you have to check a box and then you have to provide that contact information. What's happening is that you'll see a member check the box but not provide the information, or not check the box and then provide the information. So you kind of have this situation where the intent was good, but psychology and marketing theory tell us that you shouldn't do two items on the same line. And so we're getting stuck in a loop, and we're finding that our members on the application aren't really filling it out the way that they want to. And so then we have to follow up and clarify with them. Right. We're happy to do so, but there's a better way to do that.
Right, and I agree with that, but I really am trying to understand, and I won't ask it. I'm trying to ask it a different way. So, like, today's law requires that they be on the same line?
No, it was the way that HHSC implemented the bill from last session.
Okay. All right. Very good.
Dun-dun-dun.
Members, any other questions? All right. Thank you.
Thank you.
I am actually going to call out the resource witness, if you don't mind.
Please do.
Sorry, I can't leave that there. Chair calls Hillary Davis, although you already knew that, but thank you. We have you as Hillary Davis from Health and Human Services on the bill. Is that correct?
As I bring
She
I
tears
am
it.
so sorry.
Coming out your check.
It is an afternoon. I apologize. Yes, I am here on the bill.
All right, thank you. I guess you heard the discussion. I don't know, or the question, rather. So is this something y'all don't have authority to do now?
So what I can speak to, because I am here on the eligibility side, so I know what's on the application, how that process works. And I'm trying to get the notes. I apologize. The contracts itself are silent about the MCOs being able to obtain consent outside of this eligibility application process. So it's not that it's prohibited, it's just the current guidelines within the contracts don't specifically speak to it.
Okay, and from an implementation standpoint, HHSC has felt like that meant that they shouldn't, or that just means that they're uncertain, so they're not?
It was just, we were implementing the bill as directed.
Meaning, did you?
So as.
But if it was silent, there was no direction, so.
Correct.
Sorry. So does that mean that y'all told them not to, even though it was silent? And I know you have to do that sometimes if
It
it
was
doesn't
just
speak to it.
And I may need to defer and take that back. It's my understanding what is written in the contract is specific to this application process that is in current statute.
Okay. And I know sometimes we get mad at you for taking flexibility, and then sometimes we get mad at you for not. So I was really just trying to understand. I wasn't trying to shoot at you. Members, any other questions? Thank you very much.
Thank you.
Being a resource witness is not that easy. You have no idea what questions are going to come. So it's, thank you for that. So at this time, there's no other ones signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 2802? Seeing none, public testimony is closed, and the chair recognizes Vice Chair Rose to close on House Bill 2802.
Thank you again, Mr. Chairman. You know, text messages are the most common form of communication in our society, and allowing providers to contact their beneficiaries is the most convenient format that would allow more applicants to succeed in navigating the Medicaid system. And it also By allowing this, we will allow applicants to opt out of communication rather than opt in, which reduces miscommunication and confusion. And anyone who knows me, I'm about access and people being able to access their health care. And so I close, Mr. Speaker. Oh, Lord. Mr.
Careful now, don't get me in trouble.
Mr. Chairman.
Oh, thank you.
See, I shouldn't have drunk this Dr. Pepper. I should have stuck with my Coke. But
If there's no objection,
wait a minute,
object to the-
wait a minute.
Oh, I'm sorry.
And reported favorably to the local and consent calendar. Thank you.
Okay. If there's no objection, House Bill 2802 will be left pending. Is there objection? Chair hears none. House Bill 2802 is left pending without objection. Whew.
I did have a
All right.
crazy dream last night, and this must be.
This is not appropriate. We're hot micing right now. We got a hot mic right now. All right. You don't get this at other committees, by the way. All right, I think we're gonna lay your bill out. I think we'll do 4065 as well, and then we test the other one. We're gonna vote on the bills after this whether they're here or not. I'm trying to get the other two members back here, so we've texted them. So the chair lays out House Bill 4065 and recognizes Vice Chair Rose to explain her bill.
Mr. Chairman and members thank you for the opportunity to lay out House Bill 4065. So according to the 2022 report on suicide and suicide prevention in Texas by the statewide Behavioral Health Coordinating Council, youth in foster care are more likely than their peers to die by suicide. In the last 5 years, the rate among suicide of these youth has increased by 335%. Despite a previous suicide attempt being one of the leading indicators for death by suicide, the state currently does not track suicide attempts by kids in conservatorship. House Bill 4065 will require the Department of Family and Protective Services to track suicide attempts by kids in conservatorship. It would also add suicide attempts to the list of significant medical events that require the department to notify their parents within 24 hours. Thank you, Mr. Chairman and members, and I reserve the right to close and will answer any questions you may have.
You sure we'll have that? Members, any questions? Vice Chair Rose? All right, we do have a few folks wanting to testify. Chair calls Josette Saxon with the Texas Suicide Prevention Council for the bill, and then Hannah Gill is on deck. And I've got two other people wanting to testify. Ma'am, we've got you as Josette Saxon with the Texas Suicide Prevention Council for the bill. Is that correct?
That is correct.
right,
Shall I
thank you.
repeat it for the record?
That's all right. I don't. There's been a switch, so I'm repeating it. So your answer is yes, and you can just get
yes,
after it.
that is who I am, and I am in support of the bill. Thank you, Representative Rose, for bringing this bill. As has been mentioned, I am with the Texas Suicide Prevention Council. I'm one of the co-chairs of this network of over 150 organizations across the state, which include this is a network that is public and private. We include organizations and stakeholders working at the local level, regional level, state agencies, higher education, with the goal of working to reduce suicide in Texas using a public health approach. Key to this public health approach is data. This is a case where if we really want to reduce suicide in Texas, it's important to have the data so that we know what are the trends, are things in terms of prevention efforts working. Really, it just helps to not only inform those working directly at the level with individuals who are at risk of suicide, but also at the state level to inform policymaking. And that is why last session, the legislature directed the statewide Behavioral Health Coordinating Council to specifically look at suicide-related data for the foster care population, and then also to make recommendations. As was already mentioned, we do have data that is related to death by suicide for foster care. Thankfully, it is a low number. I don't have it right in front of me, but it's a small population, and so there are a few deaths. However, when we look at what the expected rate is for suicide death at the general population of Texas, as was mentioned, it is higher. And so what I want to mention here today, what this bill will do is give us an even more complete picture, because we know that death by suicide data is an incomplete picture. We know that, as was mentioned, suicide attempts are a leading predictor of suicide, or among the leading predictors of suicide. And so if we have a better understanding about how many youth within foster care have attempted suicide, it will not only help to inform DFPS, but also more critically help to have that information within our state's other multidisciplinary suicide prevention efforts, as well as really helping to focus some of the attention and efforts at local levels and within other organizations and stakeholders that are working to reduce suicide in Texas. And so we as a Suicide Prevention Council, do support this bill because we know that's an important piece of reducing suicide.
Okay, thank you. Any questions? Just out of curiosity, from the information that the department has, they're already doing, and I'm trying to remember the wording, but significant health changes. I presume that they would have a suicide attempt in there under health changes, but just not in a separate category, or is that wrong, or do you know?
So I believe this change is coming under, a medical, condition or a medical change. I think it just sort of adds that as one of the information pieces that would be included.
Yeah, I found it, I guess the wording is significant change in medical condition. It would surprise me if that's not in there, but I'm betting anything that you can't extract that information, that would just be one of many changes.
Correct. So
although they might also think of that as a medical change. So
I think it is one, though, too, where, again, it was HHSC, their epidemiologist who works on suicide data, the one who primarily led working with other state agencies to collect information that is available. And the only information that DFPS is collecting that can be reported in any systematic way is death by suicide, not attempt. So it could be technically, but it's not being used that way.
Okay, thank you. Members, any other questions? All right, thank you for your testimony. Chair calls Hannah Gill with NAMI Texas for the bill, and then I've got Angela Ott with the Hogg Foundation up next. So as you're coming up, I've got you as Hannah Gill, NAMI Texas for the bill. Is that correct?
Yes, sir.
All right, thank you.
Good afternoon, Chair Frank and committee members. My name is Hannah Gill. I serve as the Policy Fellow for NAMI Texas, which is affiliated with the National Alliance on Mental Illness. I'm testifying in support of HB 4065. As a former adoption case manager intern, I had the opportunity to spend many hours with kids in the foster care system. The trauma that they have endured in their relatively short lives is something most cannot fathom enduring within a lifetime. When analyzing the mental health conditions such as post-traumatic stress disorder, major depressive episodes, panic disorder, and substance use disorders, disparities exist between children and youth placed in foster care and those not involved in the system. This is critical to note as trauma and adverse childhood experiences are linked to higher rates of suicidality. When analyzing the suicide rates for foster youth population in Texas in comparison to the rest of the youth population, the disparities cannot be ignored. The 2022 report on suicide and suicide prevention in Texas conducted by the Statewide Behavioral Health Coordinating Council states that while the general youth population rate of suicide has increased in the past 5 years, the rate for youth in foster care has increased exponentially by 335%, as Vice Chair Rose stated. Previous behaviors such as suicidal ideation or attempted suicides are well-known risk factors for death by suicide. The Texas Department of Family Services collects data on death by suicide. However, they do not maintain records on suicide attempts or suicidal ideations. In order to begin to prevent suicide for Texas foster youth, we must identify the risk factors before it's too late. The passage of HB 4065 is a crucial first step in saving the lives of Texas youth. Thank you for your time.
Thank you very much. And Chair recognizes Representative Shaheen is present. So you mentioned suicidal ideation. That's not in this bill, right? This is only suicide attempts.
I would have to defer to Vice Chair Rose, but I believe it is suicidal attempts.
Yeah.
And
okay. Yeah.
No,
I mean, it's suicide. It's suicidal attempts. So
yes.
I just, just trying to make sure whether it was on there or not. And honestly, I think there's some confusion if you get into the ideation of what I hate myself. That kind of stuff
Absolutely.
can be, that gets a lot more subjective than a suicide attempt.
Yes.
Which is typically a little easier to tell, but anyway, I was just making sure because I didn't read that part in the bill. Members, any other questions? All right, thank you very much for your
Thank you.
testimony. Chair calls Angela Ott with the Hogg Foundation of Mental Health on the bill. And I show Sarah Crockett on deck, and that's the last person I have wanting to testify. So if you
Hey everyone.
go ahead and state your name.
Good afternoon, Angela Ott. I'm the policy fellow with the Hogg Foundation for Mental Health. I can also clarify at the end about the question about suicidal ideation if you
Okay.
have any follow-up.
And you are on the bill?
On the bill,
On the
yes, thank you. Again, as everyone has mentioned, HB 4065 is really simple, just requiring DFPS to collect and maintain data on suicide attempts of youth while under the guardianship of DFPS. Again, since the pandemic, we're predicting an overall rise in suicidality, which as a whole does include suicide attempts and suicide ideation, but we're only sticking to suicide attempts for this bill. And then, of course, the U.S. Surgeon General has identified that the rising suicidality across the nation is especially difficult in youth. Youth in the foster care system, as stated, experience higher rates of trauma and ACEs, which are concurrently linked to higher rates of suicidality than youth outside the foster care system. This 2022 report from HB 3980 has been brought up a couple of times. And again, it mentions that Texas only collects data on death by suicide in foster youth, but does not maintain records if a suicide attempt occurs. Previous suicide attempts are the strongest risk factor for death by suicide, and they need to be tracked rigorously to prevent future suicide deaths. Studies estimate that foster youth attempt suicide 4 times more than the rest of the youth population. But again, when we're talking about suicide attempts, suicide ideation, data is really, really poor, the data quality we have. At the state, national, and even global level, data quality and suicidality is exceedingly poor. It's not just Texas, it's everywhere. Updating the Texas Family Code to ensure that DFPS maintains records on suicide attempts in foster youth is the first step to addressing the high rates of suicidality in this population. Most people who survive a suicide attempt go on to engage in their own lives. Improved data collection allows for increased interagency collaboration on this issue and increases awareness of the pervasive and devastating effects of suicidality and suicide amongst all youth in Texas, especially foster youth and those who need it most. Thank you.
Hey, thank you. And I'm not trying to get you to change it. Everything you said was in favor of the bill, but you were on the bill.
Yes, I'm on the bill. So I provide, like the evidence on the bill.
Okay. Vice Chair Rose?
Oh, no,
Oh, I'm sorry.
I just turned it on.
Oh, okay. All right. Members, any other questions? All right. And you made a statement, I thought, about 4 times.
Mm-hmm.
What was that data for? Are you saying that foster kids commit suicide at 4 times?
It's estimated that they attempt. That's from the Texas Alliance on Child and Family Services. I'm happy to send.
That's okay. I mean, but it's an estimate because we don't have the data.
It's estimated. It's probably from a survey, but I can get you that survey
Okay.
if you're interested.
But do you know from a actual suicides how foster kids stack up?
And actual suicides in Texas? Yeah, that's in the HB 3980 report. I have it right here. I believe it was estimated that it was going to be 2 deaths per 100,000, and it was 8.7. And again, 8.7 is like not a whole number, but that's estimated from the HB 3980 report.
Okay, thank you. Members, any other questions? All right, thank you. Chair calls Sarah Crockett, Texas CASA, for the bill. Show nobody else wanting to testify on this bill.
Good afternoon, Mr. Chairman and members. My name is Sarah Crockett. I am the Director of Public Policy for Texas CASA here in support of House Bill 4065. I think this is a really important issue, and since COVID, we have, across our network, really seen an increase in suicide attempts and completed suicides, especially since the isolation of COVID. So this is an important bill. I think the witnesses before me did a great job of talking about the data collection piece of the bill. So I specifically wanted to talk about the notice of significant events. And Chairman, I'll answer your question about that. So right now there are several things in statute that require notice to parents, the attorney ad litem, the guardian ad litem, or volunteer advocate, the licensed administrator for the child placing agency, the foster parent, prospective foster parent, or relative caring for the child, and then any other person determined by the court to have an interest in the child's welfare. So the notice of significant event change requires that we're adding suicide attempt to the significant medical condition portion. So that would require anytime that there's a suicide attempt, everyone on that child's team and on their legal team and also on their placement team get notice within 24 hours. So right now, that would likely happen if the child was hospitalized as a result of their suicide attempt. But we see often, especially in residential treatment centers and other placements where there's a lot more supervision and a lot closer ratios where the kids just aren't alone a lot, right? Well, there'll be like a superficial wound where they've attempted, but it's not requiring a hospitalization. And in those cases, we might not find out about it until there's like we're reviewing incident reports or things like that, which we get once a month. So this would say like this child made an attempt to commit suicide, whether or not it was an attempt that required hospitalization. And that way, obviously, that's a really serious thing that everyone on the team, especially their parent, needs to know about as soon as possible. So this is a great change, and I think having this data will help us understand where we need to target training and support for this vulnerable population.
Okay, thank you. Any questions, members? All right, thank you very much. At this time, there's no other witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 4065? Seeing none, public testimony is closed, and the chair recognizes Vice Chair Rose to close on House Bill 4065.
Thank you. Thank you, Mr. Chairman. You know, we can't solve a problem if we do not know the full scope of it. And I believe House Bill 4065 is just the first basic step for us doing so. So that I close.
All right, thank you very much. If there's no objection, House Bill 4065 will be left pending. Is there objection? The chair hears none. HB 4065 is left pending without objection. All right, members, we are gonna vote out some bills. Y'all have been notified of those. There's a couple that are going to local and consent. When I mention that, I'm gonna look and make sure that's what they think. Just look at me askew if I say local and consent, and you got to know, then we'll back the bus up. All right, the chair lays out House Bill 1008 by Representative Turner as pending business. Members, we heard this bill in committee 2 weeks ago. House Bill 1008 relates to employment and license suspension of persons who provide care to individuals with an intellectual or developmental disability and who are under investigation for certain misconduct. Representative Shaheen offers a committee substitute. The committee substitute would change the definition of group home to be more specific and match the language across the legislation. This substitute also suspends the caregiver only if they have been found to have engaged in misconduct. It only requires HHSC to disenroll a provider from Medicaid if they do not suspend a caregiver who has been found to have engaged in misconduct. Is there objection to the adoption of the committee substitute? The chair hears none. The substitute is adopted. Representative Shaheen moves that House Bill 1008 as substitute be reported favorably to the full House with the recommendation that do pass and be printed. Clerk, please call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Nay.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 7 ayes and 1 nay, the motion prevails. The chair lays out House Bill 1009 as pending business by Representative Turner. Members, we heard this bill as well in committee 2 weeks ago. House Bill 1009 relates to criminal history record information reviews of certain individuals providing services to individuals with an intellectual or developmental disability. Representative Manuel offers committee substitute. The committee substitute would change the definition of group home to be more specific and again match the language across other legislation. It would require the provider, not HHSC, to review the background checks and only penalize the providers who do not comply. Is there objection to the adoption of the committee substitute? The chair hears none, and substitute is adopted. Representative Manuel moves that House Bill 1009 as substituted be reported favorably to the full House with the recommendation that do pass and be printed. Clerk, please call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Aye.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 8 ayes and 0 nays, the motion prevails. The chair lays out House Bill 1167 by Representative Romero as pending business. Members, we heard this bill in committee last week. House Bill 1167 relates to the licensing of marriage and family therapists, associates, professional counselor associates, and social workers, including certain out-of-state applicants. This bill ensures that licensed medical health professionals who have completed supervision hours in the state of their origin are in good standing with their licensing authority and have practiced independently for at least 2 years prior to their application in Texas, are not subject to additional review of their supervision hours, and do not need to take additional licensing exam. Representative Noble moves that House Bill 1167 without amendment be reported favorably to the full House with the recommendation that do pass and be printed and sent to the Committee on Local and Consent Calendars. Clerk will call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Aye.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 8 ayes and 0 nays, the motion prevails. The chair lays out House Bill 1290 by Representative Campos as pending business. Members, we heard this bill in committee last week. HB 1290 relates to the confiscation or misappropriation by the nursing facility of certain federal payments to a Medicaid recipient, increasing an administrative penalty. Representative Campos, you want to make any comments about this great bill?
No, just please vote it
All
out.
right. Representative Click, or Chair Click, moves that House Bill 1290 without amendment be reported favorably to full House with the recommendation that do pass and be printed. Clerk, please call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Aye.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 8 ayes and 0 nays, the motion prevails. The chair lays out House Bill 1517 as pending business by Chair Frank. I wasn't sure how to say that. Members, we heard this bill in committee last week. HB 1517 relates to licensing and oversight of certain facilities and homes providing substitute care for children in the conservatorship of the Department of Family and Protective Services. Vice Chair Rose offers a committee substitute. The committee substitute changes make technical terms like changing the word audit to assessment, which is really a little more than technical because it was a major difference in what we were trying to get out of the bill versus what a full audit would do. It also adds qualifications to a third-party assessor that a third-party assessor must meet in order to conduct the assessment. Is there objection to the adoption of the committee substitute? The chair hears none, and substitute is adopted. Vice Chair Rose moves that HB 1517 as substituted be reported favorably to the full House with the recommendation that do pass and be printed. Clerk will please call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Aye.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 8 ayes and 0 nays, the motion prevails. And I will tell you, members, there'll need to be a floor amendment on this. Somehow foster care families got removed from it, which was not the intent in the committee sub-language, but I just don't want to wait another week. I don't think it's a study bill, but I wanted to get it to the floor, so just to be aware. The chair lays out House Bill 1990 as pending business by Representative Wu. Members, we heard this bill in committee last week. HB 1990 relates to the Department of Family and Protective Services to notify certain individuals of changes to child abuse and neglect investigation reports. That Department of Family and Protective Services would notify certain individuals of changes. This bill requires notification of any changes in the child's investigative report so that all interested parties are made aware of any changes. Representative Hull moves that HB 1990 without amendment be reported favorably to the full House with the recommendation that do pass and be printed. Clerk, please call the roll.
Chair Frank?
Aye.
Vice Chair Rose?
Aye.
Representative Click?
Aye.
Representative Shaheen?
No.
Representative Ramos? Representative Noble?
Aye.
Representative Campos?
Aye.
Representative Hull?
Aye.
Representative Manuel?
There being 7 ayes and 1 nay, the motion prevails. The chair lays out House Bill 2229 as pending business by Representative Goodwin. Members, we heard this bill in committee last week. House Bill 2229 charges HHSC with collaborating with victims, services stakeholders, including healthcare providers, rental associations, victim advocates, law enforcement, and campus law enforcement to create a form which will standardize the information given to victims of violence across the state. Representative Campos offers a committee substitute. The committee substitute adds victims of stalking, harassment, and terroristic threats to who can receive the brochure. Is there an objection to the adoption of the committee substitute? Chair hears none, and substitute is adopted. Representative Campos moves that House Bill 2229 as substituted be reported favorably to the full House with the recommendation that do pass and be printed and sent to the Committee on Local and Consent Calendars. Clerk will call the roll.
Chair Frank.
Aye.
Vice Chair Rose.
Aye.
Representative Click.
Aye.
Representative Shaheen.
Aye.
Representative Ramos. Representative Noble.
Aye.
Representative Campos. Representative Hull. Representative Manuel.
Just one more?
Yeah.
Okay. All right, members, one more. The chair lays out House Bill 20.
You didn't say pass.
I'm sorry?
You didn't read the last part.
Thank you. Jumped ahead. 8-0.
Yeah.
Yeah. There being 8 ayes and 0 nays, the motion prevails. Sorry. The chair lays out House Bill 2243 as pending business by Representative Campos. Members, we heard this bill in committee last week. House Bill 2243 relates to the provision of assistance to elderly persons in obtaining certain protective orders. It requires DFPS to provide an elderly person assistance in obtaining a temporary ex parte order which will exclude an abusive individual from the elderly person's residence who has committed an act that constitutes family violence. Representative Click moves that House Bill 2243 without amendment be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk, please call the roll.
Chair Frank.
Aye.
Vice Chair Rose.
Aye.
Representative Click.
Aye.
Representative Shaheen.
Aye.
Representative Ramos. Representative Noble.
Aye.
Representative Campos. Representative Hull. Representative Manuel.
There being 8 ayes and 0 nays, the motion prevails. All right. And that is it. We're going to press pause for a minute. Be right back. So, stand at ease, I think would be the.
Oliverson, they can't get a hold of Oliverson. So just get to the next one.
What's that?
So Oliverson is supposed to be next. We'll just do.
Yeah, we are going to stand at ease for a few minutes while we get bill authors here. And members, there is.
Blake, have you texted BUC staff?
And in fairness, I told them
Well, I'm pretty sure when I said that they knew. We heard a whole bill. Rose. Well, we heard both now. You heard one of them. We voted. We left. Yes, she's done. And I told Stacy and Damien that the recording was not started. Fix it. So,
2473 and recognizes Representative Busey to explain his bill.
Thank you, Mr. Chairman and members. Thank you for the opportunity to lay out House Bill 2473. This bill would institute a series of technological upgrades to the Texas Information and Referral Network, what we think of as 211, including texting, data collection and sharing, and certain updates and improvements to the TURN website. Calling 211 connects Texans to the Texas Information Referral Network for assistance when necessities like food, housing, childcare, or other local non-emergency services. It's available 24 hours a day, 7 days a week. 211 TURN is funded by the Health and Human Service Commission, but partners with local organizations such as United Way and councils of governments to provide information referral services via the 211 call centers. Statewide call volume to 211 has experienced record levels over the last 3 years, between 30 to 70% over historical call volume, yet funding for 211 has remained stagnant for nearly 14 years. Technological advancement has also remained relatively stagnant at 211. Other states have leveraged 211 into online databases and text-based services and across state agencies to better connect residents to resources and increase efficiencies. Further, an interim report also found that 211 in Texas is behind other states in terms of efficiency, innovation, system integration. The network is simply in need of critical technology and communication enhancements. Upgrades called for under House Bill 2473 include one-way and two-way texting, granular data collection provided in searchable manner, a standardized screening tool for non-medical drivers of health, enhanced navigation services, closed-loop referrals, the exchange of resource data, and participation in a national information repository. House Bill 2473 also mandates a biennial report summarizing 211 TURN's operations, including its effectiveness, any improvements made, and any gaps or need in certain communities in the state, as well as recommendations for improving the network. I want to thank you for hearing this bill. 211 is kind of the gateway for a lot of Texans into interacting with state government. This is a way to help modernize it, make it more usable. And I'd love to answer questions if there are any. We also have witnesses that I think can speak very thoroughly on the matter, and I'd love to reserve my right to close.
Okay, and you certainly will have it. Yeah, obviously it's got a big fiscal note, but that's taken care of in other places. I'm guessing you have it in there, so.
Yeah, so to the fiscal note, and we'll have more information for the committee coming our way, working with agency and figuring out, but a lot of that will be in other parts of the budget. So it's not all, even though the fiscal note acts like a higher number, some of that's already covered, and we'll have more information to come on.
And some of it, honestly, part of my frustration, if you get efficient, if you spend money to get efficient, you only get charged with the money you spend, not any efficiencies. Of course, sometimes we don't ever get the efficiencies, but that's another.
We're working on it.
Yeah, it's very, very good. So anyway, I appreciate it. Members, you have any questions for, anybody have any questions for Representative Busey? You do have a few witnesses, and then we'll certainly reserve your right to close. Chair does call up Wayne Salter as a resource witness from HHSC. Yeah. And I have you as Wayne Salter, HHSC, on the bill, correct?
Yes, sir.
All right. Are you, I know you're available for resource, but do you have a brief, what is 211 and some of the data and that kind of stuff? I had some conversation, and just some people are very familiar with 211, some people aren't as much. So I just asked for a couple of minute overview of 211 from the agency.
Thank you, Mr. Chair. In terms of 211, our 211 structure here in Texas has two major options. Option one is commonly referred to as our Texas Information and Referral Network. And under this option, it provides callers with information and services, with information regarding services that they can access in their local communities. It also serves as a centralized information center for individuals seeking services, resources, or information in the wake of a disaster or a public health emergency. Our option number two, also known as our eligibility support services, which is our call center. This option provides callers with information regarding public assistance benefits, application processing updates, and assistance with submitting applications or reporting household changes. Under option two, it provides callers additional detailed information for the programs that the Health and Human Services determine eligibilities for. And these programs includes the Supplemental Nutrition Assistance Program, currently referred to as SNAP, the Temporary Assistance for Needy Families, TANF, and Medicaid programs such as pregnant women, children under 19 years of age, low-income families with dependent children, Healthy Texas Women, and our long-term care services, as well as CHIP and CHIP perinatal. For program or service questions that can't be handled under option 2, those callers can be transferred to our option 1, which again is our Texas Information and Referral Network. Under option 1, we have several sub-options. Option 4, it aids in the registration of the Texas Department of Emergency Management State of Texas Emergency Assistance Registry. You guys know this as a STEER registry for individuals who are seeking assistance in the time of a disaster where emergency management can quickly locate them. We also have option 5 as a sub-option under option 1. And this is activated in the times of disasters to provide callers with key information regarding disasters such as resources on evacuation routes, FEMA registration assistance, and shelter locations. We also have option 6, which is activated in time of an epidemic, a pandemic, or a public health emergency. And lastly, we have option 8, which provides information on referrals to mental health and substance abuse supports in local communities.
Okay. Thank you very much. Representative Shaheen, you had some questions?
Thank you, Mr. Chairman. Thanks for being here. So it sounds like what this bill's doing is it's talking about making the website more robust and so forth. So whenever I see investments in technology, I expect some kind of return. So either individuals can handle more transactions, or they're having to interface with human beings less, and they get their answers, or can even do applications on the web and that type of stuff. So you have both a website and then you have a call center. So is anybody looking at, when you make the investments in the website, actually making it so fewer people actually have to call the call center and can just handle the transactions on the web, so that either A, we can reduce the number of people in the call center, or B, you can keep the same number of people in the call center, but they can, handle more difficult transactions. So is anything like that being looked at? Because that's how you get a return in the investment that you're making.
Absolutely. That's a part of the enhanced data and reporting. So as we make updates to the website, ideally you would want to increase the ability for individuals to self-serve, which will reduce their likelihood that they would need to speak to a call agent. So we'd be able to track that data to look at those individuals who are hitting our website, who are self-serving, and compare it to historical data of those individuals who have transferred to talk with them.
Are you able to look at how many people transact with the web, and then how many calls that are placed into the call center, like on a monthly basis or a quarterly basis? Is that tracked?
We do have web data contact as well as the call volumes, correct.
Okay. All right. And then lastly, if I go to the website and it's given me information on different services, does it actually have links to where then I can go ahead and start the application process, or is that something like totally disconnected and I got to go find that website and start that process?
So for option 1.
Right, and I'm talking about option.
Right, option 1.
Yeah, option 1, yeah.
So it depends on the services that you're looking for. Typically, it's referral, and it's not an application that they will apply. So if they go on the website and they search for local community resources, such as diabetic supports, they'd be able to self-serve and find those entities within that community that they could actually go to. So it's not per se an application that they would need to complete.
When you go to the website, is there any state agencies that would it lead you to any state agencies that would provide services, or is 211 100% local resources?
It's all encompassing. So there are, even in our system, individuals who are looking for WIC services. We would self-refer them back to WIC, which is housed within the agency.
Okay, so let's talk about WIC really quick then. So specifically for that, let's say I'm on 211 and I'm a mom that qualifies for WIC. Can I go ahead and start the application process through this application, or do I have to shut down, pick up the phone, and call a different agency or a different person, or do I have to go to a different website?
So once you pull up the information, it should pull up our agency website that individual can click on those links on that website. So there should be some hyperlinks there.
Okay.
But they still have to apply through the actual website.
Okay. Well, if it has a link to that website, that's probably all right. Okay. I think I would be interested in probably having some additional discussions with y'all, just so I understand the processes here. Whenever you make an investment in this technology, there's a significant opportunity to not only drive efficiencies, but be able to handle like significant spikes that occur. So, for example, Texas Workforce Commission, when literally 1 million people went unemployed, they became overwhelmed and they were backlogged, and quite frankly, it was like a year before they recovered. So anyhow, a lot of that can be automated and drive some significant savings. So I guess I'd be interested in maybe doing a follow-up with you if I can do that, if I can reach out to you and talk about that. Thank you, sir. Thank you, Mr. Chairman.
Do you have just rough, and I don't know if y'all have it somewhere, but rough order of magnitude of what are the top 10 reasons people go to, or top reasons that people go to the 211? And then I was curious your traffic between the phone calls versus the website. I'm assuming that is changing pretty dramatically over time. 10 years ago, nobody went to the website, or maybe 15. Maybe it's been a while. Do you have any of that data?
Yeah, we can follow up with the actual top 10. I know the top 2 would be shelter assistance. In the top 10 would be shelter assistance and utility assistance. But we can definitely get
shelter assistance, like literally money?
Helping with rent, or, an extremely high light bill, utility bill, people are seeking services. But we can definitely get that list.
Because there's a ton. I went on the 211 website, which I can honestly say I had never been on, but a couple days ago, and I just can't. I mean, there's an amazing amount of information there. But sometimes almost too, you can have an amazing amount of information, and that kind of makes it a challenge to find. Okay. Thank you very much. Appreciate it. Members, any other questions of the resource witness? Thank you, Mr. Salter. Chair calls Charlotte Myers with the Community Council of Greater Dallas for the bill, and then I've got Stephanie Mace on deck.
Good afternoon. Thank you for hearing me. My name is Charlotte Myers. I'm the CEO of Community Council of Greater Dallas. We have the Dallas area 211 call center.
Okay. And we show you for the bill?
Yes, and I'm speaking for the bill.
Okay. Thank you.
So I want to talk to you about why 211 is worth investing in. Last year, fiscal year 2022, we fielded 200,000 calls for assistance. Our top calls are for shelter, whether that's rental assistance, utility assistance, sometimes it's motel stays, and food. And it's usually the majority of the people who call us are needing life-changing services. The reason that the investment is so important in improving our efficiencies is because, as Vice Chair Rose indicated when she was talking about her bill, we still have a large percentage of our population who there's a big digital divide. They don't have broadband access. They don't know how to use the 211 website. They don't have access to the 211 website. This is what they use when they need help. They have a phone and they can call 211. And what this bill would do would be, one thing that I want to focus on is it would enable texting. And let me give you an example. A typical call that we might get at the 211 call center is a young mom who has just lost her job. Her landlord has raised her rent and she needs rental assistance. We can connect her to organizations within her zip code that can provide her that rental assistance. When she asks if we can text her the information, we can't. So she has to get a piece of paper and write it down. She transposes the numbers and gets them wrong. But she doesn't know that, and we don't know that until she hangs up and tries to get the rental assistance. Can't get a hold of them. She tries to call us back. Maybe she can get through to us, maybe she can't, because we are underfunded and we don't have enough people to handle the calls we get. So for the 200,000 calls that we do get, there's 200,000 that we miss. Now, some of them can go to other call centers, but some of them just don't get answered. If she does get back through, she's going to get one of our call center people again who's going to take the time to give her the exact same information that they already gave her, and they're going to spend a little more time to make sure she gets it right. That's the inefficiency that we're trying to cure with this bill. If we could just text her the information, we would know it was right, and we wouldn't have to go through those multiple calls. That's the first thing. The second situation is, imagine in a disaster situation. And a lot of the people that reach our call center, most of them want to talk to a live person. They don't want to go through an automated menu. They want to talk to a live person. The people that know how to navigate the website, and the upgrades there would be great. But we also need people to be able to answer the phones. Imagine if you have just been through a tornado or a hurricane and you're trying to access assistance and you're told, can you get a piece of paper and write this down? It just doesn't work. And I also want to make sure that you all understand that the calls we get come from all over. So, for example, I went and looked because I knew we had a couple of representatives from Collin County. We got over 14,000 calls for assistance from Collin County last year. And again, most of them are for things like food, utility, and shelter.
Okay.
The 211 call
Need you to go ahead
system
and
is a vital service, and we are asking you to please support it.
All right, thank you. Members, any questions? So who funds y'all's organization?
The
The state? Okay,
Yes.
so the state is funding that? Because there's local, we're sending a lot to local, but so you set up regionally then?
We're in Dallas County, and we're funded by TURN, by HHS, but then we can get calls from other areas. And we are one of the few 24-hour call centers. So some of the smaller call centers, we get their overnight and weekend calls.
So just to make sure, so you're not a government agency,
No,
though?
we're a
Okay, so
nonprofit.
y'all are, okay. I just want to make sure on the bill versus for the bill. Okay.
Yes.
Very good. Members, any other questions? All right, thank you very much. Chair calls Stephanie Mace with United Way of Metropolitan Dallas, also for the bill, and then I've got Paul Fassbender on deck.
Thank you.
Okay. I've got you as Stephanie Mace, United Way of Metropolitan Dallas, for the bill. Is that correct?
Yes, sir.
All right, thank you.
Thank you. Good afternoon, Vice Chair Rose. Thank you for the opportunity to speak before you today in support of House Bill 2473. United Way of Metropolitan Dallas is a social change organization that unites the community to create opportunity and access for all North Texans to thrive. In our region, many of our neighbors are grappling with the effects of inflation as prices have increased for food, school supplies, housing, and nearly every other necessity. Subsequently, there are more individuals looking for help to access food, emergency assistance, job training, home repairs, legal services, health insurance access, and so many more, and so much more. There are thousands of nonprofits in our community and a maze of social services, and 211 plays an important role in providing tailored referrals based on the specific needs and zip code of the caller. By serving as a connector to health and human services agencies, nonprofits, and faith-based organizations, and disaster relief resources, it saves time and resources for nonprofits, eliminating the need to set up their own information line, and reduces confusion and avoids frustration for families in need of critical services. We support House Bill 2473 and its enhancement to 211's ability to partner for and connect her to the social service sector in our community. Families and providers across the state already know and trust the 211 brand. It's time to improve its efficiency and innovation and implement communication enhancements. Community members want to be able to text and to receive information, and nonprofit and corporate partners want to leverage the data-rich resource database to better support Texans in need. Thank you.
Okay, thank you very much. Members, any questions? Oh, not so fast. Now you're safe. Oh, I'm sorry. Representative?
Oh, no, never mind. I'm good.
Okay. Thank you very much.
Thank you.
All right, Chair calls Paul Fassbender with Unite Us, registered for the bill. Paul Fassbender made it through we show him not testifying. And then Ashley Harris with United Way of Texas for the bill. Got you, Ashley Harris, United Way of Texas for the bill?
Yes.
Okay. Is that correct, ma'am?
Yes, sir.
Sorry. Thank you.
You can give him the plate.
Good afternoon. My name is Ashley Harris with United Ways of Texas, testifying for House Bill 2473 by Representative Busey. On behalf of Texas United Ways, including those that run 12 of our 25 211 call centers, thank you, committee members, including Representative Campos and Representative Rose, for all your support of 211 and leadership on 211. Chair Frank, before I touch on some of the key points, I did want to share with you statewide data on 211 that shows call volume over the last 6 months. And if you, on the back page, it shows kind of the breakdown of the housing and shelter needs, which are the top kind of reason that folks are calling 211. It breaks it down a little even further on what those specific housing and shelter reasons are, so if that's helpful. So today I just want to kind of touch on some of the key challenges that our 211 network has faced and how this bill supports recommendations. So first and foremost, you've heard this today, that there's a huge lack of texting capabilities for 211 that makes it really hard for folks to be able to connect 211. I would say if this improvement was in place already, most recently it would have supported last week when the 211 call line was down for 2 days and there was no other way for our call specialists to connect with Texans who needed services. There was no other alternative in place. I'm sure HHSC might be able to share a little bit more about that, but if that improvement was already implemented, we could have kind of had a nice workaround when an outage occurs. This also can, support during times of disasters when some of our call centers are overwhelmed. During Harvey, our United Way for Greater Houston, that manages the largest call center in Texas for the Houston area, actually went down, and the other 211 call centers across the state had to pick up those phone lines. So texting would be another way in which we can really maximize those call centers to their during those very challenging times. Additionally, I want to add that this bill really works to address the limited operability between 211 and other systems, such as our Help Me Grow initiative, such as the child care portal that we have implemented in our state, allowing for the 211 resource database really to be leveraged within across state agencies and across state programs, so they're not creating their own information and resource databases, which would really create more efficiencies in our state. An additional investment in 211, as well as the passage of House Bill 2473, we believe would really modernize the 211 network, which we celebrate 20 years of 211 in Texas statewide this year, ensuring that the state can fully maximize and leverage those capabilities and enhance 211's ability to serve as a front door connector and data resource for Texas communities. I appreciate Representative Busey for his leadership and work on this bill, and happy to answer any questions the committee may have.
Okay, thank you very much. Members, any questions? Yes, Representative Hull.
Thank you. I think this is great, what they're trying to get at. I just had a couple questions on, do you know the screening, if it's verbal or if it's online? Do you know?
So I know for when a caller reaches 211 via the phone line and talks with a call specialist, there is kind of a very brief initial screening to determine kind of what the caller's needs are and potential resources that would help support those needs. In the bill, when we talk screening, we would love, most 211s across the nation are working with healthcare partners to provide a more detailed screening of maybe some other barriers or challenges that a beneficiary is facing that could impact their health status. And so we hope that this could maybe open the door to allow, 211's call specialists are already doing these screenings, maybe to expand their skill set to be able to address more needs.
Okay, and do you know if, because I know it talks about tracking, do you know about if they're getting consent for the tracking?
Yeah, so currently 211 call centers, and HHS may be the best resource on this, but they're not getting any personal identifiable information. It's just some of the demographics that they are collecting is, are you a veteran? Are you a kinship caregiver? And some age and gender demographics, again, at the consent of the caller, to better match services with more, vulnerable populations.
So if the caller didn't want to give some of the demographic
they don't have
information,
to.
Then
Yep.
Okay.
They would still just get information for whatever they need.
Got it.
Yep.
Thank you.
Yeah.
Thank you very much. Members, any other questions? Okay. Thank you very much for your testimony. At this time, there are no other witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 2473? Seeing none, public.
When he comes up, I wanted to ask him a question.
Okay. Seeing none, public testimony is closed, and the chair recognizes Representative Busey to close on House Bill 2473. I do think Chair Click has a question, though.
Absolutely.
Out of curiosity, what motivated you, or
serving on the Select Healthcare Committee this interim with yourself and many of you, and just learning a lot more after getting on that committee and kind of being more new to this healthcare space, learning how many challenges there are behind 211. Sometimes it's backlog, just time, outages, whatever it be. And also, I think coupling that with my work on the IT caucus and Representative Capriglione, who's on that select committee, we're talking it through in ways that we thought we could kind of mold those worlds together to help. Just need for modernization here is the gateway for so many people interacting with our state government, and let's, kind of goal is to get with the times a little bit to just make it more user-friendly and more accessible for everybody.
Thanks.
Thank you. To your point, Representative Hull, it won't change. It'll still, you have to consent to give that data. It's just hoping to be able to collect more to make it more user-friendly. But again, consent is there if you choose to do it. Any other questions, members?
Yes. Representative Noble.
I'm here, sir.
Thank you, Mr. Chairman. I'm looking at your list of information they might gather from someone. Second page of your bill.
Yeah.
I'm just curious. I can't imagine someone texting me and asking me my race or if I'm a veteran. I mean, I'm just trying to picture what that would look like. I would leave the text immediately if that kind of question started happening. So is that just in the, like trying to plug somebody in would those questions come up, or is that something else?
To give you a 100% answer, I'd get some clarification, but I think what it is just when they're collecting the data, they would ask if you're willing to share that kind of information so they can track who's getting served, how people are getting served across the state of Texas.
And then they could completely opt out of that as well?
Yes, absolutely.
Okay, thank you.
Okay.
Chairman, thank you so much. This is a modernization that's much needed, and I hope to have y'all support. And I'll close.
Very good. If there's no objection, House Bill 2473, House Bill 2473 will be left pending. Is there objection? Chair hears none. House Bill 2473 is left pending without objection. Okay. The chair lays out House Bill 2983 and recognizes Representative Oliverson to explain his bill. I do understand you may have some changes you want to talk about, but we don't have the committee sub in front of us.
That's correct, Chairman Frank. Good afternoon, Chairman and members of the committee. I appreciate you all allowing me to discuss House Bill 2981 today. We do have a committee substitute. It was not given back to us in time to be ready for this hearing, so we made the decision that we didn't really want to lay that out before you.
Okay. Would you mind restating the bill number? I think we may.
I'm sorry. It's 2983.
Yep. Very good.
My mistake. A little typo there. Yeah, so it was not, it just wasn't quite ready, and so.
You've had nothing on your plate lately. I don't understand how.
Hey, just stay by day, right?
That's right.
I am really excited about this legislation. And let me just say before I kind of get into this that the main difference in the community sub and the filed version is that we tried to be even more precise in bracketing this concept that I'm going to lay out before you to a target population that we know for a fact is much more likely to listen to physicians' advice regarding nutrition and diet and making appropriate healthy changes. And that's women who would be Medicaid beneficiaries who would be pregnant. That studies show that pregnant women, it's a time in their life, it's a season where they do tend to think more about, just going to go to McDonald's. Well, no, it's not just about me right now. It's about me and my baby. So studies have shown that's a great population for this. So the concept of what we're talking about here, an estimated 60% of the adult population in the United States suffers from at least one chronic health condition. And the vast, vast majority of those chronic health conditions are diet-related. Those health conditions totaled cost the healthcare system in the United States trillions upon trillions upon trillions of dollars. That is, I can tell you as a doctor, and Chair Click can tell you as a nurse, that is the bulk of what we do in healthcare is manage chronic conditions, whether it's in the clinic, whether it's in the hospital or the operating room, or you end up having surgery after surgery. It's one of those things that has always bothered me as a physician that we talk about treating chronic illness, but we spend a fairly relatively small amount of time talking about prevention. And it turns out that the things that we do that are prevention related are different than the things that we do for treatment related. So we can prescribe medications that cost thousands upon thousands of dollars per year. We could put you in the hospital, in the ICU. We can take you to surgery and cut off your leg because it's got gangrene and it has to come off now. We can do all of this stuff. But what's infinitely less expensive and infinitely more productive is to get to you before you're 100 pounds overweight and you have diabetes and you've smoked, 30 pack years and you have heart disease, and talk to you about lifestyle changes. And one of the biggest lifestyle changes that you can make is what you eat. And I think we all understand this. I mean, I think everybody, whether you're a doctor, a nurse, or a layperson, we all know that you are what you eat. And I don't suppose it would probably shock you to find out that there are people in our state, many of them are Medicaid beneficiaries, who we can give them all the prescription drugs in the world to treat their chronic illness, but the basic fundamental problem that they have is that they don't have access to healthy food. Or they might have access to it, but they don't know how to prepare it. They don't know how to make sure that the portions are the right size. And so, partially because of access, partially because of learned behaviors, the reality is that you have a population of folks who don't have Whole Foods next door and don't have somebody in the family who has a degree in nutrition. And so there are these limitations and these barriers. And so the thought process here, and this has been done in other states, by the way, with really very promising results, is could we shift the conversation in healthcare, specifically in the Medicaid population, to where we're actually paying for prevention instead of waiting until people get sick and critically ill and then spending trillions of dollars more? It turns out that for the cost of one short inpatient hospital stay, and by that I mean less than a week, you could provide a Medicaid beneficiary with 7 complete months of food, nutritional counseling, meal preparation, and total nurse-family partnership level come alongside support. And so you think about how many hospitalizations does somebody with obesity and diabetes and high blood pressure and kidney disease and heart disease, and these things stack upon themselves. And once you get down this pathway, the damage is done, right? So it really is about prevention. I feel strongly, and the data supports, and I believe we'll have witnesses here that will conclusively prove to you today, that it would be a very smart investment that would pay dividends and potentially even bend the cost curve down on what we spend annually in the Medicaid program if we started investing in prevention instead of waiting for people to get sick and then taking care of them when they're in the hospital and they need medications that cost tens of thousands of dollars per year. So that is the concept here. Now, I will tell you the bill as filed does have a fiscal note. We knew that was going to be the case. We have a rider in the budget for it, and we overestimated. We actually requested $30 million, and as you can see, the cost per biennium is $8 million, which I think is a really modest investment for a strategy that could very well save the state hundreds of millions of dollars in the years to come. It's a trial. We're going to try it out. This is a time-limited thing that we're going to approach. We're going to approach it scientifically. We're going to agree to pay for these services. We're going to allow managed care companies to reimburse directly for these services. And then we're going to keep data, and we're going to see what are the outcomes. Did we lower hemoglobin A1C? Did we reduce maternal mortality? Did we improve mental health? Did we improve physical health? What is the general state of the Medicaid population that's treated with this preventive strategy as opposed to waiting until they're sick? And if it doesn't work, members, then it expires on its own and we don't have to renew it. But I am confident that healthy food is good medicine, and we can prove that this works. And with that, I'll take any questions you have.
Okay, thanks, members. Any questions? Chair Click?
Yeah, it really is. There are so many non-medical drivers of healthcare cost. And, I mean, this is another example of things that if people would exercise and eat healthy, that they're not going to experience a lot of health, adverse health conditions and cost.
Absolutely. I couldn't agree more. And I think that of all of those non-medical drivers that you mentioned, the one that has the largest number of published, controlled, randomized trials, we talked a lot about trials yesterday and validity of data, the one that has the most amount of backing is nutrition. That is unequivocal. You can say what you want about housing or community or, various things, and you may say, well, I'm not sure, maybe I believe in that, maybe I don't believe in that, but it is unequivocal in the medical literature that nutrition impacts general health to a much larger extent than even heredity, and it has a much better chance of preventing or reversing the course of illness than medications alone.
And everybody's got to eat.
Absolutely.
And you and I have had this conversation because I think on one hand, and when we talk about healthcare costs in this country, we are literally twice as expensive as the rest of the first world, and a lot of it, honestly, is some of it is just we pay more for the same thing. Some of it is our dietary, exercise, culture, and habits. And so I love what you're trying to do here, and I obviously wouldn't have said it if I don't love a lot of concepts. And I've had this conversation, but also want to share it with members as we work towards a good solution, because I really do want to work with you on getting there. The government is uniquely bad at changing people's behavior, particularly a group of people who literally are paying zero because there's no personal incentives in any of the Medicaid stuff, right? There's none, zero, zip, and it's one of the biggest problems with the Medicaid is there is no buy-in from the patient. There's no personal responsibility required. And I'm trying to figure out from an implementation standpoint, how do you get somebody, how is it actually going to work with the agency who is implementing this? Because the implementation matters.
So that's a great question, Chairman, and I can ask the agency. I was just going to say, no, I wouldn't ask the agency. I think I have some stakeholders here that are representative of the community where they've already been doing this on a trial basis. We are not inventing a brand new wheel here. This is something that's already happening. It's already happening. Driscoll is already doing this with their health plan in Corpus Christi and in the Valley. There are food banks in our major urban populations, the Dallas-Fort Worth area and the Houston area, where they are already collaborating with entities like Legacy Community Health Centers, where they've been trying this out. But the thing is, there hasn't been broad uptake because there's no finance behind it. There's no reimbursement behind it. It's basically done with grants and sort of, hey, that's great, I'll help you out kind of thing. The food bank says, hey, we'll come alongside you, we'll help you out with that. But what this would do, which is different, which I think would really open the floodgates on this, is this would actually say in the Medicaid program, you can pay providers for these services, and the state will put will put its money where its mouth is. So I'm just going to say, I'm going to let them make the case to you, and hopefully they can convince you. They've convinced me. I believe that they already know how to do this at the ground level, and they're going to execute it flawlessly.
Okay, thank you. Thank you very much. Yes, Representative Manuel.
I just want to honestly say, because it's kind of personal, thank you for this. My aunt was a principal for years, and by the time she found out she had cancer, it was stage 4, and it was ovarian cancer, and it had spread, and they told her the reason it spread so fast was because of the foods that she ate were feeding the cancer. And that's something that a lot of people in our community, especially in African American communities, what we eat is what is killing us. And we're trying to get people who are cancer survivors are the ones who will often say, maybe rethink what you're eating because it could literally be killing you. And that's, I'm sorry, this is just so very important. I think if we can put pamphlets in the mail, we can tell people that they can, you know, there are healthier options to use with the assistance that you're getting, because literally if she would have, had gotten checked, yes, but within a year it had gone from she thought something was wrong to it was stage 4. But it was the driving force that every doctor from Houston to Beaumont to Port Arthur all said it was just how she ate, and it just drove that. So thank you for bringing this up.
You are very welcome, Representative. And let me just say that I want to do you one step further than that. And I want to say that it's not, what we're contemplating here is not just about sort of dropping fresh fruit off at the door. What we contemplate in these services, and what I think my stakeholders will talk to you all about, is that this is farther than that. This is about, in addition to what you described, this is about, you know, there are going to be places where, yes, we could provide a bag of fresh groceries, but the home doesn't have a refrigerator. Or maybe the person who does all of the cooking learned to cook from somebody, a relative, and the only thing they knew how to do is fry everything. And that's not healthy. And so this is more about a comprehensive approach to breaking down these cultural barriers, addressing the inadequacies that the community might have with regards to making sure that good, healthy food is available. I am definitely sensitive to the fact and a firm believer that there are people in our state, participants in the Medicaid program, where the only 2 options that they have within walking distance to their home for food is McDonald's and the convenience store. And neither of those is an option that's compatible with a long, healthy life. So I'm there. I appreciate you, sir.
You're absolutely right. And part of my districts have food deserts, and it is Burger King, McDonald's, and then you can go to the convenience store. So thank you so much.
Yes, sir. Sir.
And thank you very much. Members, any other questions? All right, we'll reserve your right to close. And Chair calls Nicole Lander with Houston Food Bank for the bill, and then Holly Poinsett is on deck. And I get that right? Nicole Lander, Houston Food Bank for the bill, is that correct?
Yes, sir.
All right, thanks. Go ahead.
Good afternoon, Chairman Fink and the members of the committee. I am Nicole Lander, a registered dietitian, and I work as the Chief Impact Officer for the largest food bank in the United States of America, Houston Food Bank, and I am in support of HB 2983. Thank you so much for this bill, bringing this bill forward, and I want to thank Chairman Oliverson for his leadership on HB 2983. At the largest food bank in the nation by distribution, Houston Food Bank and our affiliate food banks provide more than 150 million nutritious meals every year to a service area of 18 counties in the southeast region of Texas. Our mission of Food for Better Lives means that we strive to provide nutritious food, programs, and services aimed at helping individuals and families achieve long-term stability and not have to return to food pantry lines. We do this work in collaboration with over 1,600 partners, including schools, pantries, and healthcare organizations like Legacy Community Health Center. I want to emphasize that food banks understand their community's need for nutritious, healthy foods, and especially for those in families that have underlying health conditions, specifically diet-related conditions. As you heard Chairman Oliverson say, medical nutrition programs such as produce prescription and medically tailored meals have shown to be highly effective in saving healthcare costs and improving healthcare outcomes. Just as doctors' offices write prescriptions for medication, medical providers providing produce prescriptions write prescriptions for healthy foods for targeted populations among individuals screened for food insecurity and other diet-related conditions. FoodRx is a program the Houston Food Bank offers, which is a produce prescription program that provides 30 pounds of fresh produce plus other pantry staples for their household for not only the family member that is impacted by the condition, but those around them. Food is Medicine programs for pregnant women during postpartum care can provide adequate nutrition, improve pregnancy outcomes, lower health care costs, reduce risk factors for complications with birth. Houston Food Bank has specifically worked with pregnant populations in partnership with various stakeholders, including the Center for Children and Women, Texas Children's, Harris Health, Northwest Health Center, and Community Health Choice Plan. Our partnership started in September of 2022 and has found that we were able to reduce some health biometric indicators through the distribution of this food program. We provide unique operations like door service, pantry, client choice, and other specific options. Food banks are well positioned in communities to utilize our logistical infrastructure like expansive fleet, state-of-the-art food production facilities, dietitians, and other key stakeholders to provide these services to communities. Thank you again, Chairman Frank and the members of committee for this, and I hope you will vote HB 2983 out of committee. I am open to any questions.
All right, thank you very much. Members, any questions? All right, thank you for your testimony. Chair calls Holly Poinsett, testifying for self and Texas Academy of Nutrition and Dietetics for the bill. Did I get that right?
That's correct.
All right, thank you.
Thank you, Mr. Chairman and committee members. As was stated, my name is Holly Poinsett. I'm here on behalf of myself as a registered dietitian nutritionist and also as a board member of the Texas Academy of Nutrition and Dietetics. We're fortunate in the state of Texas to have over 7,000 licensed and registered dietitians across the state. And I'd like to first begin by thanking Chairman Oliverson for bringing this bill forward, for your leadership in recognizing the important policy link between nutrition and these health outcomes, which ultimately reduce long-term healthcare costs to the state. We're really encouraged when we heard you bring up this discussion during the interim hearings of the House Select Committee on Healthcare Reform that several of you were a part of. You know, multiple studies do show, it was mentioned already, that when nutrition and when a registered dietitian is a part of the treatment team, healthcare costs go down, hospital stays are less, fees if they're in the hospital are less, and number of days of work missed are reduced as well too. You know, we believe this pilot project that's outlined in House Bill 2983 provides both a realistic and a measurable way to test what we anticipate will show to be a cost-effective nutrition intervention to reduce the prevalence and the severity of the leading chronic diseases that have been mentioned. You know, evidence-based strategies are at the foundation of most healthcare, or all healthcare professionals, hopefully, but certainly the foundation of the practice of dietetics. And we are incredibly encouraged by several of those aspects that are laid out in this bill. For example, number one, the use of a comprehensive, collaborative, and a multidisciplinary community-based approach. That's been a proven strategy. It's designed that way in a scientific way. The use of tangible metrics that are able to support measurable outcomes, which are so important. This, you know, pilot program is laid out in a very scientific way to be able to show more of a cause and effect and not just an association. Things like markers like hemoglobin A1C, other cardiac markers like potassium, sodium, use of medications such as insulin as well too. Very tangible ways to show the outcomes from this intervention. And then lastly, we appreciate the inclusion of a licensed and registered dietitian as an integral part of this team. We know that chronic diseases such as heart disease, diabetes, cancer, and obesity are among the leading causes of both death and disability, not just in Texas, but in our nation. And nutrition plays a critical role in the prevention of these chronic diseases. You know, as a practicing dietitian, I feel very passionately that it's time we go beyond handing a photocopied piece of paper of something when someone's discharged or leaves a doctor's office on what they either should or shouldn't be doing. That doesn't, to your point earlier, that doesn't elicit change. There needs to be buy-in, and I do agree with you on the cost mechanism. What's different, I think, about this bill is it teaches them the how to do that, to implement that, to bring that into their family. It's important that we provide the right nutrition at the right time to the right individual. And dietitians are the nutrition experts who demonstrate the knowledge, the skill, and the competency necessary to provide that nutrition therapy, and we're honored to be called out as a part of this program.
Okay, thank you very much. I don't know if you're one of the ones that is already doing this. Okay, you are not. You are not. Okay, because I'm assuming with the way we do currently with the way we do Medicaid, it's a capitated rate. So I presume that you could go to an MCO, not an MCO, but an MCO, and if it is cost effective over a certain amount of time, this is something that they theoretically could already do in a capitated rate situation.
Yes,
don't point
but
to anybody.
I will defer
that's
to
and
those
I think
that
to
are
some
already
degree,
doing the program. The answer to your question is yes, but I'm certainly not the expert on that, and there are others in the room that are.
Okay, and okay, thank you.
Yeah.
Members, any other questions? Okay, thank you. Have we already done him or no? Chair calls Paul Fassbender with Unite Us. I guess, that's where I've seen that name. He wasn't at the last one. So we will show him testifying for the bill, but not, for the bill, but not testifying. And then Chair calls Jackson Griggs, Texas Association of Community Health Centers, for the bill. And then Shreel Sharma is on deck. Okay.
Good afternoon, Chairman Frank and committee members. I'm Jackson Griggs. I'm a practicing family physician and the CEO of Waco Family Medicine. I'm representing Texas Association of Community Health Centers today in support for House Bill 2983.
Okay.
Community health centers, or FQHCs, offer accessible, affordable primary care to all, regardless of insurance or ability to pay. My health center has 15 clinics in McLennan and Bell counties, serving patients from all ages from 17 counties in Central Texas. In fact, Waco Family Medicine last year served 62,000 individuals, over a third of whom had Medicaid. And we provide prenatal care to to low-income women in our community and annually deliver over 1,000 babies. In Texas, FQHCs serve patients with multiple chronic conditions, witnessing food insecurity's impact on chronic disease. Factors outside the medical visit, like inaccess to affordable, healthy foods, have major influences on health outcomes, such as cardiovascular, renal, and metabolic disease, as well as related economic burdens to Texans. And pregnancy is a critical area where nutrition influences health and economic outcomes. Poor maternal nutrition increases risks of congenital anomalies, of gestational diabetes, of hypertensive disorders in pregnancy, negative neurocognitive development. But improving access to healthy foods in conjunction with care management has resulted in important health behavior changes among our patients. During clinic visits, patients receive prescriptions for healthy food, and outside of clinical encounters, patients receive care management services by social workers and nursing staff to support their health goals. Since 2017, Waco Family Medicine has distributed over 10,000 boxes of fresh produce to our patients and introduced weekly cooking sessions for patients. Women attending our prenatal care patient education groups show dietary behavior changes when receiving produce coupled with education. We know that quality nutrition in pregnancy yields better outcomes in mothers and babies, and we see interventions like ours as scalable with adequate funding, and believe the long-term return on investment is substantial. We strongly support interventions like Food as Medicine programs and the pilot HB 2983 would create for high-risk pregnant women on Medicaid. And notably, the current bill excludes Waco Family Medicine from eligible pilot communities due to population requirements, but we hope to discuss this further. We're excited about Food as Medicine programs' potential to improve vulnerable women's health, and the bill's data-driven approach could help quantify the impact of these programs in terms of health improvement, Medicaid cost savings. So thank you for the opportunity to share with you. I'm happy to answer questions, and in particular, the question that came up about behavior change, if you're interested.
Okay, thank you very much. Members, any questions? Representative Hull? Noble.
Thank you, Mr. Chair.
I'm not as tired as him, and I still do that. I do know the difference. Representative Noble.
I'm just curious how this a prescription for healthy food works. I'm not familiar with that term, and so I'm just curious I can't picture that being written in Latin and given to a pharmacist. So what does that look like?
Great question. So I taught family medicine for 13 years in the residency environment, from labor and delivery all the way through ICU and inpatient, outpatient. And one of the things that really discouraged me is I kept telling patients, well, we need to get you eating better, and here's a list of healthy foods. Here's foods that are metabolically toxic or that are going to lead to a second stroke or worsening heart failure. And we have these conversations, and yet the patients would continue to eat the same way, and we'd have this conversation over and over without major change. And I partnered with, this was actually a concept that I developed with a friend who was running a local farm. And so in 2017, when the initial prescription produce program developed, the farm was harvesting the food, they were boxing it, and then I was writing prescriptions for produce and then handing the patient a box right out of a refrigerator right outside of my office, a box of produce, and then we talk about it. As the produce prescription model developed, we put prescriptions, recipes in English and Spanish in the box so that our Spanish-speaking patients, we developed culturally specific recipes for folks in our diverse population. And then we tested it, we published on it, and demonstrated that patients develop more self-efficacy and belief that they can sustain behavior change when they're prescribed produce prescriptions.
Okay, thanks. And I guess you mentioned a grant. Was that a federal grant? Was that a local grant that was, I guess, paying for the produce that you're writing a prescription for?
Episcopal Health Foundation. So Prevention Institute has a model called Community-Centered Health Homes. Episcopal Health Foundation was willing to invest some in this model, which invests in non-medical drivers of health issues and leverages the FQHC relationship with the community and with specific patients in order to execute on changes in those those non-medical drivers. And so this was one of the ways in which we used that money from Episcopal Health Foundation to pay the farm, to harvest the food. We're now working with a food bank to expand the produce prescription program, and the food bank has limited funding, and so we're just not able to do this nearly to scale. As I mentioned, we have 62,000 patients, and virtually every one of those patients could potentially benefit from some education and behavior change in terms of how they eat and how they approach health behaviors.
Okay, and what are the reasons somebody changes their dietary habit? Because I know some of it is access, some of it is, but some of it is just deciding to change. So
Absolutely, you posed a great question earlier, which is why change, right? Why change if you don't have
McDonald's tastes better?
Yeah, right, exactly. If you don't have financial stake in the game. So the model that we teach, and it's evidence-informed model that's been in the psychological literature for a long time, and now it's been adopted in primary care, it's called motivational interviewing. Motivational interviewing identifies ambivalence in a patient and leverages that ambivalence to help a patient achieve their own health goals. So it's not heavy-handed. It's not like, Representative Frank, you really need to stop smoking. It is instead, flossing or getting better sleep or more physical activity. I mean, you name the thing, and you're going to say, well, I'd like to do that better or more consistently or more, but here are all the barriers. Motivational interviewing is a structured way of leveraging the trust and rapport that you have with patients to help them come to their own conclusions about behavior change. So using that model of behavior change with patients, coupled with the very physical, you can smell it, you can taste it, you can cook it. The produce prescription gives them that extra oomph to make the behavior change. We've seen it over and over again in patients. Motivational interviewing helps. Coupled with something physical like a prescription produce, it's very impactful.
And by the way, I don't mean to.
No, it's a great question.
This is the way I process.
I'm ready for the next.
But honestly, I mean the prescriptions for food is 10 times better than most of the garbage that we have people,
Absolutely.
the pharmacies that we throw down people. So I really don't have as much of a problem with that. I do think aligning incentives matter a lot, which is what's a challenge in the Medicaid system. Yeah, because of that. But I do appreciate what the FQHCs do a ton. Did you say y'all do 1,000 births in the FQHC?
We do. Usually,
I didn't know any FQHCs delivered babies,
1,200 to
although I know
1,600.
Waco's pretty far ahead of a lot of FQHCs.
We don't have a birthing center, but our doctors do the prenatal care, and then they do the deliveries at the hospitals.
Okay, that's what I thought. I was like, I wasn't aware that there were any baby deliveries at the FQHCs, but the doctors are doing it. Okay, very good. Members, any other questions? All right.
Great.
Thank you very much.
Thank you so much.
Chair calls Shreel Sharma from University of Texas Health Center at Houston on the bill. Did I get that right? Shreel Sharma?
Yes.
Okay.
Well, good afternoon. My name is Shrila Sharma, and I'm professor and vice chair of epidemiology at UT Health Houston School of Public Health. I'm also a registered and licensed dietitian in the state of Texas, and I'm providing resource testimony on House Bill 2983. So food is a need, not a want. Also, one has to eat healthy to live long and live well. Some of the largest healthcare costs in our country are associated with nutrition-related chronic diseases such as obesity, diabetes, heart disease, and 13 different types of cancers. Food insecurity, healthy eating, and disease are intricately linked. Families that are food insecure are on a limited budget, and as a result may eat readily available processed unhealthy foods as available, thus impacting their health and affecting their working and earning potential. The economic cost of the nutrition-related chronic diseases among 18 to 64-year-olds is estimated at $16 trillion from 2011 to 2020. Unfortunately, for approximately 1.5 million Texas households, consistent access to healthy food is a distant dream. In partnership with healthcare and community organizations, I have spent the last 2 decades implementing and evaluating solutions to address this issue in Texas. One such set of solutions are medically tailored meals, medically tailored groceries, and healthy food prescription programs. We recently conducted one of the nation's largest clinical evaluations assessing the impact of Houston Food Bank food prescription program on 2,000 plus food insecure adults with diabetes across 17 healthcare agencies. Results showed a clinically meaningful improvement in diabetes control over 6 months and lowered medical costs. These results confirmed that food prescription programs can be effective when implemented at scales in our Texas communities. We are now focusing on high-risk pregnant mothers. Some of the highest healthcare costs in the lifespan are associated with preterm birth. In partnership with healthcare and managed care organizations such as Texas Children's Health Plan, Harris Health Systems, and Community Health Choice, as well as community organizations such as Houston Food Bank, About Fresh, and Brighter Bites, we will implement evidence-based food prescription programs and medically tailored groceries. And we will evaluate the impact of these programs on improving pregnancy outcomes, such as weight gain, diabetes, hypertension during pregnancy, as well as birth outcomes, such as preterm birth in high-risk pregnant mothers receiving care at health systems across the greater Houston region. The important program put forth in House Bill 2983 will allow Texas to expand this effort to mothers and babies across our great state and assess the cost effectiveness of these programs when administered at scale. Thank you. And I'm happy to answer any questions.
Yeah, thank you very much. Members, any questions? All right. Thank you very much for your testimony.
Thank you.
Appreciate it. I think there's nobody else, right? Oh, I'm sorry. Yeah, Chair calls Rachel Robinson, Legacy Community Health, for the bill. I show nobody else wishing to testify, so if you're wanting to, please get registered. Okay. And I guess if we could just clarify, because you have somebody else from your organization against the bill. That maybe, I think.
No, that's an error. That would.
Kind of thought so. So y'all might just, it's fine with me, but I just pretty,
Yeah, Dr.
y'all may be conflicted, so I don't know.
Sorry.
But anyway, I've got you as Rachel Robinson
Yep.
with Legacy Community Health for the bill.
Correct.
Okay, thank you.
I'm not aware of any.
No, I'm sure it's nothing, it's not that easy to get registered all the time.
So good afternoon, Chairman Frank and members of the Human Services Committee. My name is Dr. Rachel Robinson.
Mind just stepping up just a little
And I'm
closer.
the medical director of OBGYN at Legacy Community Health in Houston. I'm here to testify in support of HB 2983. So at Legacy, we are proud to be the largest maternal health care provider in the nation in the FQHC setting, caring for over 12,000 underserved moms a year. Legacy currently employs the FoodRx model, where physicians identify at-risk individuals that would benefit from dietary interventions. Legacy currently collaborates with the Houston Food Bank to provide the service to our patients. Eligible patients are referred to a dietitian and sent home with a food prescription. Twice a month, these patients are invited to drive up to a pharmacy, which is a mobile grocery store provided by the food bank and is adjacent to a Legacy clinic. Patients can shop for healthy food, fruits, and vegetables that can lead to reductions in body mass index, lower A1C, and glucose levels. All of these interventions are done without having to resort to costly medical interventions. So all Legacy facilities are in underserved areas and overlapped with food deserts, with patients with the highest need and high incidence of food insecurity. This is why it's imperative to have the food to come to the clinic. Presently, all this work is funded through a patchwork of various grants and the Houston Food Bank. We are creating a robust program, but truly do not have sustainability and funding when we know this medical intervention is so important. Our team of community health workers and over 50 AmeriCorps members have the data to prove this is working. We've worked as a coalition with the Rockefeller Fund and UT Health to put some results behind our claims. This pilot is thoughtful because moms care about having a healthy and full-term baby. I have seen so many women who did not take their health seriously before pregnancy and suddenly become some of the more compliant and trusted partners in ensuring their health and health of the baby. So during pregnancy, poor diets lacking in key nutrients can lead to anemia, preeclampsia, hemorrhage, and even death. They can also lead to stillbirth, low birth weight, developmental delays in children as well. Suboptimal diets, as many have testified already, are a leading risk factor for chronic diseases such as obesity, hypertension, and diabetes that significantly impact maternal health. So food as medicine interventions provide access to optimal nutrition, reduce risk factors, and improve outcomes, and must become a formal, consistent component of pregnancy and postpartum care. We look forward to continuing the work on this pilot and improving the lives of our new moms and babies. Thank you, Chairman Oliverson, for bringing this bill to legislator, and I'm happy to answer any questions.
Thank you very much. Members, any questions? Thank you very much for your testimony. At this time, there's no one else, no other witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 2983? Seeing none, public testimony is closed, and the chair recognizes Representative Oliverson to close on HB 2983.
Thank you, Mr. Chairman and committee members. So appreciate all the testimony that we've heard on this. It's a thoughtful discussion. I mean, this is clearly taking healthcare in a little bit of a different direction, but I think a better direction than where we've traditionally gone. I hope that you heard, when I think about bills, I'm always thinking like, okay, what is the problem that we're trying to solve here? And so I hope what you heard today is that this isn't a new concept, that this is something that's been done, it's been proven, it's been implemented, and it's been implemented well. But the issue is that there's not a consistent and reliable source of funding because it's not typically considered to be a, quote, medical service, unlike very expensive pharmaceutical drugs that we would consider paying for. So typically what would happen is if it's not a grant or some charitable donation that's being made, it's typically a managed care provider in the Medicaid space that's essentially using a portion of their profit in order to fund this as a trial balloon. So what we're proposing to do then is essentially move this into its own essentially agreed to, cost codes, that this would essentially be a service that could be reimbursed as any other regular eligible Medicaid benefit that could be provided, as opposed to sort of doing it in this grant-funded piecemeal. Well, we'll do it when we can. When we can't, we can't, and all that kind of stuff. I did bracket the bill primarily to large urban centers. I'm very sensitive to what the doctor from Waco had to say, and truthfully, if that's something that the committee would feel more comfortable with, I'm open to that. But what we were trying to do is really sort of nab the biggest urban areas where we knew there was the highest concentration of beneficiaries that could be in need of this service. At the same time, extremely good food bank resources with a lot of community support and history of having implemented this and implemented it well. Because again, this is a pilot, and we want to put our best foot forward, and we want to show that this can be very successful.
Okay, Representative.
Take any questions you have.
Yeah, Representative Noble has a question.
Thank you, Mr. Chairman. I just have a question on the information you're going to collect of the recipients of this pilot project. Are they going to give you permission to? I mean, this sounds like HIPAA violation kind of question.
Yeah.
So that's what just made me curious about that. Would you
Yeah,
have
I mean,
to opt
we would
in
have to follow all appropriate IRB protocols and be HIPAA compliant and things like that. But
so
at the same
before they
time,
could participate, they would
I think
have to
what we're
agree?
asking is for HHS, as this is ongoing, to keep track of that information as part of their,
So HHS has the ability to find out people's body mass index.
I'm pretty sure they can
measurements and
they
blood
can know
pressure
that.
and all that.
Yeah, I mean, I'm sure a lot of that. I mean, we talk about HIPAA, but remember that under HIPAA you have an exemption and a clearance to access protected health information if it's necessary to do your job, and those that are financial payers have broad exemptions to HIPAA with respect to how they use that authority in order to do their job. So and I'm saying that I'm not a lawyer, but unfortunately I have to sit through CME every year on HIPAA for about 6 hours. And I know that there are specific exemptions in there that I'm pretty sure. I'm happy to work with HHSC on that, Representative, to make sure that the data collection piece is seamless.
Not just that it's seamless, but that the individual's privacy are protected as well.
Yeah, absolutely.
Thank you.
And if I could, just
of course,
before you say those magic words about close, but down the road, because right now this is the state's going to pay, or the Medicaid, but state and federal, is going to pay 100% of all the people and the food, and we're going to pay 100%. There's no buy-in from the patient.
That's right.
It's Medicaid, so
right.
State's going to pay 100% of the
Yes.
professional, 100% of the food.
Yes.
If it's successful, and successful being obviously healthcare outcomes one, but there's also been testimony about this is also going to save money, then are we going to calculate how much money, because that money is going to be saved to whatever MCO you go to. If it's successful, that MCO is going to save. They're going to be paid the exact same capitated rate as if we hadn't done this. We're going to spend, as a state, we're going to spend more money, and they're going to keep that. I think at a minimum, we need to make sure that that is tracked so that if and when this gets rolled out, I don't know. I don't think that's contemplated in there. I just, I'm convinced, and I'm totally with you, really. I'm in violent agreement with you that food, exercise, all of that stuff is correct. I am also completely skeptical of our ability to implement this with the integrity that I think will make it successful. And so, concept's awesome. Our ability to do this is what is in my doubt. So, but
and I agree with you. And I guess as you're talking, I'm thinking, the reality is that for all of its inefficiencies and frustrations that you and I have had many evening conversations and cup of coffee conversations within the Medicaid system, it still is a better level of health care than no health care. And it is pretty good at delivering basic medical services, primary care services, and showing up to pick up the tab when somebody shows up with chronic medical conditions gone awry. So, I mean, there is a track record of being able to
absolutely
provide services, pay the bills. We made a decision to go to managed care. I think it was the right decision from the standpoint of, I think it creates a proper financial incentive to invest in services that are cost effective. In my conversations with the MCOs, they're very much in support of this too. And they see this as, if this was actually sort of part of the regular Medicaid menu of services that they could essentially count as part of their reimbursement and such. And if there was money that was specifically for this reason, this was factored into the capitated rate, that this is something they would all embrace readily. It's just that right now they're limited to doing it more in sort of a trial balloon fashion because they've got to have extra money available to invest in it. It's a we have to take some of our own and invest it in that kind of thing. So it makes it disjointed and not very predictable, and it makes it hard to really roll it out on a statewide basis.
Okay. Thank you.
Thank you so much, and appreciate your favorable consideration, and I close.
Very good. Thank you very much. If there's no objection, the bill will be left pending. Is there objection? Chair hears none, and House Bill 2983 is left pending. The chair lays out House Bill 3584 and recognizes Representative Lee O. Wilson to explain her bill.
Thank you, Mr. Chairman and members of the committee. Thank you for the opportunity to lay out House Bill 3584. Whenever safe and appropriate children in conservatorships should always be placed with family first. However, family is often located only late in a case, or a located father may only have alleged paternity. In the 8 to 9 months needed to adjudicate these familiar issues and claims, DFPS has rightly will not place a child with an alleged father or an alleged father's family, and that is the correct thing to do. Unfortunately, in many of these cases where a relationship is established, the department will still withhold custody to avoid moving the child after such a length of time. While that is an instinct that is very understandable, that is also an injustice to both the families and the children in question, and my bill would remedy that. Thank you.
Okay. Thank you. Members, any questions? All right. Very good. Yes. Representative Noble.
So I see your there's kind of a hierarchy here. And yet, if a child's been with someone that was fostering to adopt for a year or more, then they would automatically have the child taken away in order to be with the blood father. Is that even though that child had no relationship with that familial person, is that the intent of your bill?
No, that's not the intent. Right now in Chapter 264, it doesn't contain this language. So all other language would still apply. But in this case, the courts and the department have stated that the priority placement of family in that safe and healthy hierarchy, that would be only applicable to when it gets to the end of the adversarial hearing. So we're saying that if after 8 months they've worked out those family situations, they've confirmed that is the father of the child, because sometimes it's alleged that, well, they're not really the father, so they can't go there, which, until that's worked out, DFPS should not put the child there. But this would make that, upon confirmation that this is a safe and healthy environment for the child, this is a family member that is now confirmed, even though it might be 8 or 9 months later, that child will be moved. It's the best thing for the child and for the parent.
So, but the way that I'm reading your bill, it actually, that person moves ahead of someone that they have had a long-term relationship with in a foster parent kind of situation.
Well, that is their hesitancy, that child has already now formed a relationship with that family for those 8 months, but still the ending of the case, if it's a safe and healthy environment, is to return that child to the family. to either the mother or the father. And so, you know, delaying that is not healthy for the child.
Thank you.
And any other questions?
Thank you, members. Any other questions?
And I reserve the right to close.
Yeah, you will certainly have it. Chair calls Julia Hatcher. There's two people. Julia Hatcher testifying for self and TAFDA for the bill. Is that correct?
Yes, Chairman Frank, committee members. Thank you so much, Representative Leo Wilson, for carrying this bill. My name is Julia Hatcher, testifying on behalf of myself, as well as the Texas Association of Family Defense Attorneys, otherwise known as TAFTA, and we are in support of this bill. And to answer some of your questions, Representative Noble, because I don't want to repeat everything that Representative Leo Wilson said, this bill is really important because this language is actually passed last session as an amendment to 2926, but it only ended up in Chapter 262 of the Family Code, which is regarding the initial removals. So what's been happening in the last year and a half is that the department has been applying this language. It's a hierarchy, and it comes right out of the ICWA statute in federal law, so that when the department has conservatorship, whether temporary or permanent conservatorship of a child, families first, kinship is next if there's no family, foster is next if there's nobody, and then finally you're looking at a RTC or a shelter. And that, like I said, that language comes right out of federal statute. Because it's in Chapter 262 right now, the department has only been applying it to pre-removals. Once the adversary has happened, if there is no family that is found immediately, which is often the case, or if we have an alleged father, which is often the case, normally the case, children can't be placed with the family of an alleged father, right? And it may take months, because we have to rely on the Attorney General to do paternity testing. It may take months before we actually find out that the alleged father is the father, at which point then the parents want, or the father, he either wants his child, or if he can't, he wants his family to have the child. And what we're dealing with is, well, now the child's been wherever the child's been for several months, and we don't want to move the child to his family. Well, sorry, but the family, that father has a constitutional right to have his child, and the child has a right to be raised by family, which we all know children want, as long as it's safe and appropriate. So this bill would actually just duplicate the language in Chapter 264 that is already in Chapter 262, so that across the case, the entirety of the case, children are being placed with their family or in that hierarchy. That's all this bill is really doing.
What would take so long? You said the Attorney General is the only place that can do these tests?
Well, the attorney, in the statute right now, there's a statute which requires the Attorney General's office to work with DFPS in establishing paternity for fathers, and that's because the Attorney General's office pays for it. The state pays for it. Why does it take so long? I mean, it just takes the Attorney General a long time to do anything. I mean, they just have a lot of cases. So, I just had a case recently where we had an alleged dad in November. Mom named him as an alleged dad. He was ready to test. We did an initial test with the AG. Then the AG realized the paperwork was wrong. The judge signed an order with a wrong name in it because there wasn't another alleged dad and they forgot to change the name. So the lab threw out that test. So I represented the alleged dad. He had to go back in and do another paternity test. Judge didn't sign the order for 4 months. So that's why it takes so long. That was probably, and hopefully that was an anomaly, but I mean, AG, they can take 6 months to test these dads.
Because from a prioritization standpoint, I certainly understand why, I mean, the blood relative makes sense because there really is something about blood. I mean, and the why it takes so long to find somebody and the emotional damage that you're doing to the child first and foremost, but frankly also to foster parent when you say, hey, you're going to adopt this kid, and then whoop, 6 months, 8 months later, we just pull it. That is, may ask the resource witness actually to come up to figure out, because Because really what we're doing here is just changing the priority, or really we're not even changing the priority, we're making it consistent in this part with what we already did last session.
Right,
That we've always had preference for blood relative,
Right.
correct?
right, right,
So I don't know that I consider this a ton of a change,
right.
but I really hate the situation. And honestly, we do this in a number of ways where we drag a foster family on and then pull the rug out from under. And again, it's not just them. It's the kid thinks you're going one way and then jerk them another way, and it can be prevented. So, members,
Well,
any
and a
other
lot of
questions?
these are babies too, and so babies don't really know. I mean, they're not,
Yeah.
well,
Members, any other questions? All right, thank you. Chair calls Mercedes Bristol Self. This is the last one I show on this bill. Show you as Mercedes Bristol Self for the bill. Is that correct?
Yes. Thank you, Chair. And
I think I heard you say yes.
yes, I'm for the bill.
Very
Yes.
good. Thank you.
Mercedes Bristol, I'm for the bill. And thank you, Chairman and representatives. I had a situation where I was in court with a paternal grandmother. And so Dad and the girlfriend did not want to acknowledge or put the child with the paternal grandmother. So she didn't get a chance to be selected. So we were in court, and DFPS was there, and they were talking, but they actually said we didn't have any contact with the paternal grandmother. But grandmother was subpoenaed, and we were in court, and I'm sitting there next to her. I represent Texas Grandparents Raising Grandchildren.
Yeah.
So I was sitting next to her. And so I stood up, and I went and asked the attorney for DFPS. I said, the paternal grandmother is here. And he never said anything to the judge. So after the whole thing, and the child was already in a foster home. So after the court, I went and approached the bench, and I asked Judge Garcia if I come and speak to him. And I said, paternal grandma was in the room. And so he turned around very angry, and he said, can you talk to them? And he turned around and asked the attorney ad litem to talk to us. And so that's the only way the grandmother was able to be acknowledged. So I think that this bill, I think they need to really look beyond what parents want, for the child. And that child was placed in a foster home and was there for quite a while.
Okay. Thank you very much. Members, any other questions? Okay. Thank you very much for your testimony. Chair calls Erica Manuelos with DFPS Resource.
Good afternoon. Erica Bañuelos, Resource Witness.
Okay. With DFPS?
Yes.
Okay. Does this change what does it change in your mind in current statute?
So
actually, from a practice standpoint.
Yes. So we currently have policy in place that is pretty similar to what is being asked, which is we always, at the time of removal, we actually, there's a, already by family code, we have something called the caregiver resource form that parents have to fill out at the time of removal to identify any relatives to be placed with. So right now, our policy is we first look for relatives. We look for fictive kin after that. Then we look for a foster home. And as a final option, it would be a GRO where we would place the child. So the way we look at it is we always want the children to be in the least restrictive environment.
Which that's the same four priorities in the bill.
Yes.
In order.
Yes. That what the bill would do, it would reinforce our policy, because right now it's just a policy for us.
Okay.
But it wouldn't change what we're currently doing.
Okay. Yeah, Representative Noble.
So what can we do legislatively to speed this process along for children? I'm just appalled that, obviously, if the parents don't put someone down on your form, you have no way to know. And how do we speed this process along for permanency for the children?
Absolutely. So currently, about the last statistic I saw, 34% of our kids that are removed at first placement are placed with a relative caregiver. So, and we currently, last year, I believe we were over 50%, and this year we are currently 42. The last statistic I saw was 42% of our kids are already with relatives, and we anticipate by the end of the fiscal year to be above the 50% status. So we not only do we work at it from the front end, but once CVS conservatorship gets involved, us looking for relatives does not stop at removal. We continue through the whole process of the conservatorship case to ask for relatives. And sometimes we discover dads that we didn't know existed, and so then their paternal relatives come forward, and we are open to those placements. We even have some alleged parents who then are confirmed as not being biologically related to the child. They're not the actual dad, but they have a significant relationship with them. And so we can do a placement as a fictive kin. So we try to look at every case scenario to look at what is the least restrictive and can those people meet the safety needs of the child in care.
Okay. Okay. And is there anything in policy, because I'm trying to think, this really goes off the rails when it takes too long.
Yes.
And particularly when you have somebody in a home for an extended period of time. I have often wondered whether we should actually even put a child in a foster home that wants to adopt until the parental rights are completely terminated because of this kind of thing, because of the weeping. I'm not,
yeah.
It's not the bill, but honestly, we hear this so much, and it's there's not really a question in there. It's more of a comment to my colleagues to try to. But there's not a process. So if you have a child in a foster home for a year and they're planning on adopting, y'all are still looking for an option the whole time.
We are. We continue to look for a relative. Now, what I will say is that, we do look at where the child is currently at in terms of, I believe, and I might not know exactly what the statute is, but there is something that says that foster parents, I believe, cannot intervene until a year after the child is placed in their home. Now, for foster adopt parents, which are different than foster parents, typically, I know that the agency really tries to place children with them that are very high risk for parental termination, and that has to do with prior history. If this is the fifth or sixth child that we're bringing into care, we'll approach the relative, but sometimes the relative says, I can't do the sixth baby. And so then we know that this is a very, there's not, the probability is low, so we end up placing with foster to adopt. So we try to be mindful of those placements when we do them with foster to adopt.
There's no real easy decisions that y'all end up with. I get that. So thank you very
really
much.
Difficult.
Yeah, thank you for your testimony. At this time, there are no other witnesses signed up to testify. Is there anyone wishing to testify on, for, or against House Bill 3584? Seeing none, public testimony is closed, and the chair recognizes Representative Leo Wilson to close on House Bill 3584.
Thank you very much, committee and chairman, for hearing this bill. I do still believe it's most important if you have two parents that love that child and it takes a while in the process. I agree with you. That's heartbreaking. And one that supports CASA and all sorts of alternatives. It needs to be speeded up. I appreciate that. And I also appreciate the resource witness as well. I know their job is hard because you get emotionally attached to the kids in your case. And so I appreciate all that they're doing. I just believe that while it's difficult to move a child back to a parent, once that parent is confirmed or found or all of that is taken care of, I still believe that that's the best scenario for that child.
Okay.
Thank you.
Close?
Close.
All right, very good. If there's no objection, House Bill 3584 be left pending. Is there objection? The chair hears none, and House Bill 3584 is left pending without objection. Members, we have two more bills, but we're going to pause to pull up. I think I've tried to communicate, but Representative Hull's bill, I dropped the ball on that. I know I tried to give you all warning, but I think I've checked to make sure everybody is good. So, right there. Yep. Okay, the chair lays out House Bill 1085 is pending business. Members, we heard this bill in committee 2 weeks ago. House Bill, thank you for coming back. House Bill 1085 relates to certain procedures relating to children placed under a parental child safety placement. Representative Noble offers a committee substitute. The committee substitute includes clarifying changes worked on with the department that says the caregiver may use existing department resources and that they may use a relative or friend who has completed a background check to provide respite care. It also changes that the terms of the agreement cannot impose an unreasonable burden and clarifies the reporting requirements so that the data is included in the federal reports where the department determines it appropriate. Is there objection to the adoption of the committee substitute? The chair hears none, and the substitute is adopted. Representative Noble moves that House Bill 1085 as substituted be reported favorably to the full House with the recommendation that it do pass and be printed. Clerk, please call the roll.
Chair Frank?
Aye.
Vice Chair Rose? Representative Click?
Aye.
Representative Shaheen?
Aye.
Representative Ramos? Representative Noble?
Aye.
Representative Campos? Aye. Representative Hull? Aye. Representative Manuel?
Aye.
There being 7 ayes and 0 nays, the motion prevails. Thank you, sir, and good luck on your layout over there. First one. Which committee? And I shall. Yeah, there you go. What's that? Urban Affairs. Urban Affairs. I will text the committee chair to make sure you know it's the first one. No. What's that?
He's going in front of me. What's the deal?
You got to know people. Got to know people. All right. Yeah, I see Cronovit. Okay. The chair lays out House Bill 2439 and recognize. Oh, I'm so sorry. That is the order I had it, which was you. So, do I need to back up or?
Can you say it? Yeah. You can call Garcia.
Okay. The chair is not going to lay out, if I said it, House Bill 2439. And Stacy, you can correct me if I didn't do that right. So, the chair lays out House Bill 3189 and recognizes Representative Garcia to explain her bill.
Thank you so much, Chairman. Thank you, my esteemed colleagues on the Committee for Human Services, the opportunity to present House Bill 3189 today. When a family is impacted by traumatic events that require children to be removed from their parents' care, it is the goal of the Department of Family Protective Services to place those children with a relative or designated caregiver who is able to provide care for them. Since 2020, DFPS has taken the initiative to prioritize familial placements, and this is a cost-saving effort to reduce the number of children placed in state care and to avoid further mental trauma on children and families. Kinship caregivers can be a life-changing resource for youth entering care. You'll hear testimony from family members and folks who wanted to step up to take care of their children or their family's children, but were met with obstacles that made it difficult to obtain housing. At 19, I became a kinship provider to my 3-year-old brother. And I'd like to give a little bit of a perspective, from my perspective, if I will, as a youth who entered care myself at the age of 8 years old. I found myself incarcerated in a cinder block cell simply because I didn't know where my mommy was. This was, typical because my mom and I, she was a real young mom when she had me, and we often hitchhiked up and down the East Coast together. And sometimes I would wake up and she'd be gone and I wouldn't see her for a long time. And incidents like this would happen often for me, but sometimes my grandmother would take care of me. Sometimes I would have an aunt take care of me. Other times friends' families would take care of me, but this time was different. Because this time, even though I didn't usually know where my mom was, this was the first time that I got in trouble because I didn't know where my mommy was. So You know, today at 45 years old, I still vividly remember those cold white cinder block walls, the metal bed frame that screeches across the floor, the people crying, women, girls crying, other girls crying and fighting even at night. I remember sitting there for days and, you know, so scared because little did I know our family members needed more than just the will to take us in. They had to actually be granted temporary custody, and their lack of space in their houses was often a hindrance to my placement, and I basically just sat there wondering why nobody wanted me. So I wanted to express this to you because a child placed in kinship care is more likely to be able to cope with the trauma of separation from family. And through familial support and often connection with their communities, they're able to thrive better. In current law, when a child is taken into DFPS custody, the department must contact every guardian and make due diligence attempts to place the child with a family member. The department has to inform potential caregivers that there's a process that includes a background check, a criminal background check, as well as a home study. However, the problem that we have is these requirements don't often include specific details about what's included in this home study. And some of those things that are included are like play areas for children, a separate room for, you know, a girl from her brother. These are things that are set in place for safety, but we can remember back to the days where, you know, 6 to 8 or 10 of us would pile in on grandma's living room floor, and we would sleep there and we were happy and we were safe and we felt loved. But, you know, things have changed a lot, and now grandparents are simply just unaware that there's an actual living space requirement that will hinder them being able to keep their loved one from foster care. So without without adequately providing awareness of department standards and these exceptions to potential familial placements, they lose their ability to be able to find adequate housing within the amount of time before their loved child ends up in the system. For grandparents on a fixed income, we need to further avoid financial hardships when it comes to these situations, because oftentimes these grandparents, I say grandparents because in my situation it was my grandparents, and my constituents that reached out happened to be grandparents as well. But I just want to put it into perspective with you. We hear that, okay, my grandchild might go into foster care. This initiates the fight or flight response. Immediately you're trying to do everything you can to make sure you can bring that child into your house. This is a child that requires food, clothing, school, all of these things that grandparents, they had their kids 20, 30, 40 years ago. They're not having, you know, worried about having to redo this again, but they're put in a situation where they have to. $1,000 for the first month's rent for an apartment. 2-bedroom, we'll be modest. $1,000 for last month's rent. $250 application fee. $500 security deposit. That's $2,750. And I'm sorry, I don't have $2,750, and I'm a pension veteran. You know, a lot of these grandparents are on fixed incomes, and I asked for full transparency from the beginning of DFPS contact, meaning let's include these little nuanced situations upon initial contact. Already DFPS is doing an amazing job with making sure that families are able to help their children that might be going into care. But just by giving them more information in the very initial contact could help, you know, remove a whole lot of these barriers that are keeping our kids in care right now. And I welcome any questions from the committee, and I reserve my right to close.
Yeah, you will certainly have it. Wait. Back up. Sorry, Representative Noble.
Is this your first bill to lay out?
No, ma'am.
Oh, you're doing a great job. No, I'm just curious about the, so you want them to spell out with the first time they contact family members what might be required, but also what waivers might be available? Is that what you're asking for in this bill?
Yes, ma'am, because basically what's happening right now is there is information being given, but there's more information that can be added, such as the waivers. A lot of folks don't know that things, exist out there that will help families obtain housing, adequate housing. And oftentimes they find out too late. And when we've spent $2,700 just for a first month's rent, and now we find out that, maybe something wasn't quite right with the spacing of the rooms or what have you, that's lost money. And it's very hard for apartments or landlords to just give that money back and say, you know what, I'm sorry that happened to you, but, so we're just trying to do everything we can to let everyone, any potential familial relatives be able to know up front that these are some barriers that could happen. And even as well, one thing that I would like to see is in the military, and forgive me, I'm retired military, so I refer to that a lot. We kind of have these flow charts, kind of like for dummy guides in a way, if you will. And on these flow charts, it tells you what to do if perhaps, you don't meet a specific requirement. Like, what is the next step? We just want to be able to offer something other than, sorry, too bad.
And do you know if these requirements are the same from all across the state, or are they different in some areas? Do you happen to know that information?
From my understanding, this is for the entire state of Texas.
I'm gonna call the resource witness up.
Yes.
All right, thank you.
That is
Thank
my
you.
understanding.
So I appreciate you bringing the bill. You're talking specifically about people taking it under people taking in these kids under the current kinship program where
Yes.
where we pay 50%. And I'm going to ask this to the resource witness, but are there any differences in home requirements for a kinship placement versus standard foster care? Do you know?
I think that there, and excuse me for saying I think, but I believe that there are type of waiver style situations for actual family versus foster.
Right.
I believe that the requirements might be a little bit more stringent for non-familial foster parents.
And I think that's the case. So I think, but I don't know that that's good enough, because honestly, when you start with a tape measure and measuring rooms,
I don't think so.
Right. Yeah. I mean, but I think we've got to look at that. So I'm going to call the resource witness up, because I think while information matters, sometimes if you're still requiring them, it's like, yeah, I gave you information, but now I'm going to send your kid over here because, I mean, frankly, if you've got a 5-year-old boy and a 3-year-old girl in the same room together, whoopie-doo, right? So that's an official line, but I mean, it's like, but it may not pass, right? So
I will say personally, I have 8 children. I'm blessed that they're mostly boys. They're all boys for the most part. But even those of us who have large families, if we went by the state guideline
you would not be
of
allowed
how
to
many
keep your
kids
kids.
per room, I mean, it's really unfair. If anything, it kind of puts an added barrier on those large families who don't have as much resources.
Yeah, and honestly, I'd rather look at the underlying than have waivers, because waivers require decision making. Decision making requires time. Anyway. So thank you very much, members. Any other questions of the representative?
Thank you.
And we will reserve your right to close. I am going to call up Erica Banuelos first, please, the resource witness. Going to wear you out. Thank you for being here. Got you as Erica Banuelos. Am I saying that name right?
Yes, it's Bañuelos.
Banuelos.
Bañuelos. The
Bañuelos.
N is has a little tilde at
Bañuelos.
so it's Bañuelos, not with
Bañuelos.
Yeah,
Bañuelos.
You're doing good, yes.
All right. With DFPS resource witness on the bill, correct?
Correct.
Okay. So what are the differences, just big picture, not the whole thing, but so foster parent, kinship placement, foster parent, we're actually doing a study on that, and we require a lot of things, and we measure the size of the room and the height of fences and all this stuff. What is waived for a kinship placement?
Not a lot. So yes, so I think what the bill is referencing is so there's verified and unverified, right? So unverified is typically what we have when we talk about kinship. There's not a lot of verified kinship caregivers, and that really has to do with there's a different standard for them.
So what is the difference between verified and unverified?
Yes, so verified means that they've gone through the licensing process
Oh,
at
okay. Just
HHSC, so they have to meet the square footage.
But if they're verified, they're just a foster home that is also kinship.
That's correct.
Right? So they're a fully licensed foster home that also happens to be kinship, so they're going to get paid 100% of, they can get paid, because we do it 50% of
Right.
the basic, regardless of what that kid is for kinship.
That's correct.
And then, but if they're fully verified, wasn't sure that term, so they get,
100%.
they get whatever, the
They get the
100%,
pass-through.
and they get it at the, whichever level the child is at.
That's correct. But the hard part for relatives is, imagine you get called to take in 5 kids, they're not ready. You know, they have a certain living space like she was explaining, but if they want to get to getting verified, they have to meet the minimum standards of what a foster parent, who that's what they're like, we want to foster. They know what's going to come with fostering, right? What needs to be, what kind of, what does the house have to look like? Plugs have to be covered, all that. Our kinship caregivers are typically at the onset of a placement, they're not ready for that.
Of course.
Yeah, so when we work with our kinship caregivers that are unverified, we do have a minimum sort of standard of living, which means that the space has to be safe, it has to be appropriate, and for unverified, we're not looking for square footage. We're looking for, is the child safe in your home? Do
Right.
you have enough space for them?
Well, that does sound like there's a significant difference, though.
Absolutely, there is.
Okay, I thought you were saying there wasn't much, that we
Oh,
don't
I'm
we
sorry.
don't waive much.
Oh, no, it's very different.
Okay.
Yes. So if they have to go through the licensure of getting an actual license, getting verified, there's a big difference, which that pertains to every foster parent. If
Right.
they're just unverified, then it looks different. But it's a lot harder to get licensed.
Right. Yeah, absolutely. Is
Sorry, I feel like I
should be.
confused you. I apologize.
No, I may have heard the wrong. I think this. Yes, Representative Noble.
Thank you so much. Okay, so I'm curious, at what point can they just stay, if it's an emergency situation and you put them in somewhere and you find that it's a safe place and it's appropriate, can they just stay in that arrangement in perpetuity as a placement, or is there come a point where you say, now you have to meet all these other requirements?
No, they can stay, our relative caregivers can stay unverified through the entire process, and we can actually award them PMC, permanent managing conservatorship, without them ever being verified.
Great, thank you.
But the money always stays at 50%.
That's correct, for unverified.
Okay. Members, any other questions? Thank you very much. I'm going to ask you one because it's something are the differences between verified and unverified written down anywhere? I guess it's just because it's not in statute. When we did the kinship funding, I don't recall doing anything to change the standards. And I guess y'all have done that on your own.
No, we are working right now with HHSC in partnership to look at how we verify kinship caregivers. And then there's also some proposed federal changes through the Administration of Children and Families, where they are proposing that relatives have a different type of standard versus foster parents.
I almost wonder if it wouldn't make sense to put something in the bill asking y'all to officially look at it and make recommendations to the legislature of what laws would need to be changed, if any.
Mm-hmm.
I don't know if that's hard. I don't know. I don't want to mess up the bill, create a fiscal note or anything. So thank you very much.
Yes.
All right. All right. We do have a few people wanting to testify. I have Mercedes Bristol, self with Texas Grandparents Raising Grandchildren for the bill. Is that correct?
Yes, for the bill.
All right. Thank you. And I've got Richard Garza on deck.
Thank you again for allowing me to speak, and I get so nervous. But one of the things that I'm for the bill because I have several Since we started our nonprofit, we've have over 1,500 grandparents that have come to us for different reasons. And 90%, I'm going to say 80% of the grandparents that come to us is because CPS has closed the case and left the children with them and they're the informal. They're the ones that don't get licensed. So these grandparents are left to get, meet the requirements, even though they don't need to meet the requirements. So I have a couple of examples right here. I have a grandmother, for example, that was living with her son. Her daughter died, and now she takes in a 10-year-old. And so the 10-year-old doesn't have a place to live, to sleep. She just keeps her there. However, Dad gets involved in the picture, and she goes visits with Dad because Grandma thought it was appropriate. Well, this man ends up sexually molesting this child. So Grandma now has this child that has some issues, right? And so CPS got involved. And so CPS says, she's having issues, and Grandma doesn't know how to handle her. So Grandma made a mistake and says she needs classes. She needs some help. I need you to help me give her some help. So they take that child. There wasn't enough room in there, so they take that child, and so they put her in a foster home. So now Grandma says, I want the classes. I want to help. But there was no other relative here, so they put her in a foster home in Houston. And Grandma's in San Antonio, and Grandma doesn't speak English. So now when this happened a year prior to when she reached out to me. So now we're reaching out to DFPS and saying, what does this grandma need to do to get her granddaughter back? So in the process, this child is angry. She's got a lot of issues. So now they start giving her medication, and now she's getting a little worse. So when she asked to be put back to Grandma's, they said, well, we can't bring her back here because she doesn't have a bedroom to sleep in. So if your son is willing to go to the living room and you both take the bedroom, then we can do that. So the son didn't want to do that. So now she had to find another place to go live where she can have privacy with this little girl. This grandmother lives on Social Security. She found a little itty-bitty efficiency. So now the attorney at Lytton, they're saying this is not adequate enough. She still doesn't have a room. Well, I don't think, like the representative said, I was born with 7 brothers, and I was the only girl, and I slept in the living room because my brothers had the bedroom, right. And so it was just like, it's unfair to me that doesn't get told to them. She went out and looked for a place to be able to get her granddaughter back, but still not good enough, for them. Okay. So that's one thing.
Thank you. Oh. Yeah. If you don't mind wrapping up.
Yes, no. And so we have a lot of other cases, but I think that if they are told before, this is what needs to happen, they don't have to go out and do something that is not really what they're looking for.
Okay. Thank you very much. Chair calls Richard Garza, Texas Grandparents Raising Grandchildren, and then Sarah Crockett's on deck.
Thank you for the opportunity.
And I've got you as Richard Garza, Texas Grandparents Raising Grandchildren for the bill. Is that correct?
I am for the bill.
Okay, very good.
Yeah, thank you. Just real quickly, I do work for a child placement agency, Mr. Chairman. It's Divinity Family Services. We're in Region 3, 7, and 8. 85% of our caseload is a foster kinship foster.
Really?
85%. So it makes sense that we marry along with Texas Grandparents Raising Grandchildren. And I'm the one that represents Texas Grandparents Raising Grandchildren. Mercedes will give me all the CPS cases that she's having difficulty with. I speak Spanish as well, so I can take on these cases. And just to amplify what Ms. Bristol has said about that, it's always an issue, especially with the grandparents that we're having, in regards to space, especially space. But it goes beyond that in the sense that there's a real cultural divide as well, not only as far as Spanish-speaking versus English-speaking, but the person that Ms. Bristol was talking about is from El Salvador. So me as a Mexican-American have some disparity in her culture as well when I speak with her. So you can imagine the disparity that might be there in regards to a Caucasian person, if I can say that, along with an Hispanic grandparent that speaks no Spanish, that speaks no English, and is very just involved with her culture, and that's it. She does not understand. So that's some of the difficulties and obstacles that we see that we have in trying to get these foster parents licensed. Now, Divinity is very good about variances. As a matter of fact, some of our referrals that we get are from different child placement agencies because they don't want to deal with the variances. But the co-founders that we have want us to make sure that our motto continues, and that's getting to yes. So whatever it takes for us to get these foster parents, kinship foster parents licensed, we're going to do. And that's usually with variances. Again, as Ms. Banuelos said, this is very difficult for us to get, but practice makes perfect. So we continue to do these variances, and we do get some of these variances approved, especially when it comes to who sleeps where. And we're going to do a variance on that same family that Mercedes was talking about. You know, we can have that child living in the sleeping in the bed, and grandparent has agreed to sleep on the sofa itself. Okay. So we will continue with that.
And when you say get them to variance, are you saying get them to foster it all as unverified, or are you saying all the way to verified?
Yes.
All the way to verified?
All the way to verified, yes, sir. Okay. Because there's so many subsidies and that they become eligible for. One of the things that we talked about that was mentioned is about PMC. Well, they can get permanent management conservatorship, but they would not qualify for the PCA if they're not licensed as a foster parent for the 6 months prior to be granted that PMC. So PCA is only eligible when you have fostered that child for 6 months. Right. Okay. I see my time is up.
Okay. Thank you. Thank you very much. Well, I kind of stole some of it. Did you have any closing, or is that good?
No, that's perfect.
Very good. I kind of jumped in with some questions. Any questions, Candy? All right, thank you. Chair calls Sarah Crockett, and then Caitlin Devlin is the only one I showed testifying. So we've got you as Sarah Crockett, of course, with Texas CASA for the bill. Is that correct?
Yes, thank you, Mr. Chairman.
Thank you.
Sarah Crockett, Director of Public Policy with Texas CASA, here in support of House Bill 3189. And I think this bill is really just about trying to make this process less daunting, help make sure we're providing information that's important. As at Texas CASA, all of our local CASA programs are doing what's called collaborative family engagement, which is where we use software to do a very broad search for family members. We usually find about 3 to 4 times the family members that the department is able to find without that technology. And what we do as part of that model is bring the family to the table and just say, like, how can you be supportive? Historically, the way that it has worked is, like, we identify a family member, we call them, we ask them immediately without any warning if they can be a placement. And if the answer is no, then we sort of never talk to them again about what's happened in the case, what the child needs, and we don't involve them in the meetings or anything else. And so this collaboration with DFPS has really changed the way that we're working with families. And through this process, one of the things that we see kind of come up over and over again is family members feel like they don't have the space, or they aren't sure that they would, meet the qualifications to be a placement. And so this bill, I think, just makes it very clear, what is acceptable to the state, what's not. And there are some flow charts, and actually, if it would be helpful, I can provide those to the committee that exist that really break down, like, what is verified versus unverified, and really black and white, like a table of these are the requirements for being an unverified kinship caregiver. You do have to pass a home study. There are some requirements for housing, and then that looks very different if you're verified. And I will say, to the department's credit, and as Mr. Garza said, there are a lot of exceptions that can be made for kinship caregivers. We advocate all the time for children to be able to sleep on a cot in the living room or a pull-out couch with their relatives, and that's approved by the department. So, but it's just about making sure that communication is there and available and as transparent as possible, again, to help kind of reduce some of the fear and make it easier for kinship caregivers to say yes to being a placement.
Okay, thank you very much. Any questions? All right, what software do you have that allows CASA to find family at 4 times the rate of the agency. Is that what you really said?
Yes. So yeah, it's called Seneca. It's similar to like 23andMe or those kinds of softwares that we use in collaboration with the agency. We have access and licenses for the software, so we can find one. We have a little bit of information about the child, where they're born. And then we, like find the family tree that's out there. And it's using a lot of the same software that is kind of utilized by people, all over. So it's a great way to find, like we have an MOU with Mexico. We sometimes can find family members in Mexico that have a relationship with the child, but, no one is looking at them. So we are able to find dad and their family members as well. And it's, again, just letting them know they have a child that's at risk of or has entered the foster care system. And, please come to this family team meeting where we share information about what's going on.
Not that we don't appreciate that, but I'm just trying to figure out why the agency is not doing that, because while Texas CASA is almost around the state, it is not everywhere in the state. And
That's right.
I'm guessing we're not using that. And so...
And I will say the collaborative family engagement model is funded through the Department of Family and Protective Services, and it is a collaboration. But it is one of the things that, family finding and then like how we engage family and changing that model is.
And honestly, half the time I find out the agency's not doing something, it's because there's something in statute that doesn't allow them to. So a lot of times the finger points back at the dais. So I'm not being critical of the agency in that regard, but I would like to figure out why we're not using it, because that doesn't sound like a very expensive thing. Yes, Representative Noble.
Thank you, Mr. Chairman. So you mentioned you have the spreadsheet, the or whatever it is, a flow chart.
Yeah, it's literally like a side by side.
Does that tell the specifications for being verified, or does it just say? So literally, what the representative's bill is doing, you could provide that to be handed out. Is that what you're saying, or is it more complicated than that?
Yeah, there are a lot of handouts that have been developed, and I think we agree. I think that in ideal scenario land, everyone would become verified because there are so many more benefits available to the family. But a lot of may not be interested in that or not able to become verified for one reason or another. But it does really clearly say, like, here are the requirements to be approved, have a home study approved by the agency to be a placement. And then here are the requirements for kinship caregivers to become licensed or verified as a.
So you don't have like a here's an entry point where a child actually could be placed in your home. You don't have something at that lowest level. It's just the levels above that, it sounds like.
No, so the lowest entry level is just being unverified, which is having your home study approved by the agency. And so it talks through, it basically outlines like what is incorporated in a home study, what are, it's a criminal background check. Okay. There are some like minimum standards that you have to have, like you have to have a fire extinguisher in your home.
Do you have that on that list?
Yes.
You have that checklist? Okay, yes. Great, thank you.
Yes, and we can provide that to the committee.
All right, thank you. You have to have a fire extinguisher whether you're verified or not?
Yes, I believe so.
Yeah. Okay, thank you very much. I'm sure I can find mine. Chair calls, what's that? Yeah, what I know how to use it. If Chair calls, I would, by the way, if anybody is recording this. Chair calls Caitlin Devlin. We have you as Caitlin Devlin, self
Yes, sir.
for the bill.
Yes, sir. Yes, I'm for the bill representing myself. So, hello, my name is Caitlin Devlin. I'm a child welfare social worker in Texas. My background's in child placement. I hold a administrator's license for child placing agencies, and I am very excited to kind of maybe clarify some of the confusion. If y'all are confused, imagine like what relatives feel like. I feel like this is a great demonstration of that process. So I have prepared something, so I thought it might be most prudent just to address some of the concerns. So for relatives, there's a lot of requirements. And sometimes when you present all of the requirements at once, it can get really overwhelming. And so all of the language, it can be just really confusing. And so while I think earlier, and clarify me, but Ms. Ben Willis was saying that there's a lot of difference between the process of becoming a verified foster home and a very different process for being an unverified kinship placement. But the exceptions that can be made for those unverified kinship placements, that's not much. There's really not much difference there with what can be permitted to be kind of given as a waiver or variance. And so for relatives, there's a different rule set, but every determination for if a relative is going to be approved or not comes down to the specific child in place and the specific family and the specific home environment. Because you may have a 5-year-old and there may be certain rules that you could give a waiver on, but if that 5-year-old has a developmental disability or a medical need, so it's always so subjective, unfortunately, but then the liability goes back on the person making that home assessment. And so I really think this bill is a great, simple way to improve things for relatives, because really all it does is ask that relatives are given 2 important points about what's required and that they're given that information earlier in the process. So they're given it before the adversary hearing, so before the 14 days out of removal. There are a lot of requirements, like a fire extinguisher. We can get that at any point. But if they need to move to a different apartment, they need to know that early on so they have more time to make that change. Or if they need to have a fire inspection come out, telling relatives as soon as possible can help expedite getting the child into that placement. And so really, this bill is just clarifying some of the information that needs to be given to relatives sooner. And so there's a lot of information given to them. This bill really just pulls out, tell relatives about space requirements and tell them about sleeping arrangements, because those are the really important ones that are hard to adjust later on. Tell them that within 14 days of a child being removed, if possible, for the relatives that are included in the adversary hearing. And so all the other details, we have more time to figure those out later. And the exceptions, it's not really emphasizing the exceptions as much. It's giving them the important information they need up front so that they can get the child into placement sooner. Okay. So, any other questions on?
Good.
There are statutes on the requirements for relatives. It's Chapter 262, Statute 114. They're very broad because part of that is it's an exceptional thing for a child to be placed with their own family member, their own blood, and that kind of requires some exceptions to be made for some of the home rules. But because they are so broad, it still does become very subjective. And yes, we do have the federal rulemaking coming up for what requirements could be done with parity for relatives in foster homes, but that's still a couple years away before we're going to get that guidance from the federal government. And this bill would just say, just tell relatives about space and sleeping sooner. That's it. They still have all the other requirements. It's still the same process, but just tell them about the really tough pieces, space and sleeping, as far as the home study process earlier on so they can address those needs sooner.
Okay. Thank you very much. Members, any other questions? Thank you. All right. So nobody else at this time. There are no other witnesses signed up to testify. Is there anyone else wishing to testify on, for, or against House Bill 3189? Seeing none, public testimony is closed, and the chair recognizes Representative Garcia to close on House Bill 3189.
Thank you so much, Chairman Frank, and thank you so much, my esteemed colleagues and members of the Human Services Committee, for the privilege to present House Bill 3189. A special thank you to everybody who came to testify in support of this common sense bill. This bill has no fiscal note at this time. This is just just removing the barriers. That's all we're asking. We want to know up front what to expect and to try to, have an answer for those barriers up front for our kinship caregivers. This is an important step in ensuring that kinship caregivers and children impacted by the foster care system have support. This bill would simply ensure that DFPS reaches out to the relatives of a child to provide information as to the process it takes to have the child in their custody and the spatial requirements which are assessed in the home study. House Bill 3189 would increase transparency for family members, support kinship caregivers, and ensure that more children in the foster system grow up in familiar, loving homes. And most importantly, it'll ensure that a child won't feel like her family doesn't want her simply because of the spatial barriers to placement. Mr. Chairman, if there are no other questions from the committee, I humbly close and ask for a favorable referral of House Bill 3189.
All right, thank you very much, Representative. Great job. If there's no objection, House Bill 3189 will be left pending. Is there objection? The chair hears none, and House Bill 3189 is left pending without objection. Now, with a strong close, the chair lays out House Bill 2439 and recognizes Representative Thimish to explain her bill.
Well, good afternoon.
No pressure.
Thank you, Chairman Frank and members of the committee for giving me the opportunity to lay out House Bill 2439. At any given time, a caseworker with the Department of Family and Protective Services has an average daily caseload of 16.2 cases. Well, case range and subject matter, one thing that remains consistent is the caseworker's duty to exercise due diligence to locate missing parents and relatives, regardless of how likely it appears that the parent wishes or does not wish to remain involved in the child's life. Caseworkers, per CPS rules, must exercise due diligence at the beginning of the case and throughout the life of the case. Additionally, the department takes possession of a child. They are statutorily required to provide notice to a parent, conservator, or guardian, as well as provide information to relatives and certain individuals. While we understand the importance of ensuring children are placed with their parents or relatives to maintain normalcy, what I want to ask is what happens when that child's mother was a victim of human trafficking and that child is a result of such a horrific crime. If a mother is in a human trafficking situation, specifically sex trafficking, and ends up pregnant either by her trafficker or an individual she was trafficked to, it may be difficult to locate the family of an alleged father if she does not remember or even know who they really are or what their name is. Similarly, if the alleged father is her trafficker and manages to escape the situation, but now DFPS has to notify him or his family that he may have a child and they're under the care of that state, it would potentially place both the mother and child in danger. With House Bill 2439, if the court finds that the alleged father committed the offense of trafficking of persons as defined by the Code of Criminal Procedure, the notice to a parent, conservator, or guardian that is required when the department takes possession of a child will be waived. Additionally, DFPS will not be required to provide information to relatives or certain individuals when a child is placed in their care if the department is aware that the alleged father committed the offenses or trafficking of persons against the mother of the child. House Bill 2439 would ensure that a mother who is a victim of human trafficking and her child remain safe throughout the process. Chairman, members, thank you again for the time today to lay out this bill. I would appreciate the committee's favorable support for this bill, and I'm happy to answer any questions you may have about House Bill 2439. And if there are none, I reserve the right to close.
Yep, you'll certainly have it. Thank you, Representative, for bringing this. Was there a particular case or something in your district that...
It just, as a former CPS board member, have just seen, for me, that just as we're talking about just that delay in making sure we're protecting the mothers and the children where they spent time wanting to look for, and she had been trafficked and was known. I mean, there was a record of the police had pulled her out. We knew specifically it was a human trafficking event, and just wanting to protect the most beautiful baby from them trying to find, allowing the man to become aware of who that he had a child and protect the mother.
Okay. Members, any other questions? All right. Thank you. There's several people that have registered for the bill, but nobody wishing to testify. So tell you what, if you could, I'm just going to call the resource witness just real quick. Clint Cox, DFPS resource. and want you to get out of here without at least one question. I show you as Clint Cox, the FPS resource on the bill?
Yes, sir.
Correct. Okay. How would this change process at the agency? What changes the bill bring to the processes of the agency in terms of your investigation as you see it?
In terms of the investigation, we already have situations where we don't attempt to notify people for family violence or different things, so it would just add to that at this time.
Okay. Okay. Members, any other questions? All right, that was too easy. All right, thank you. At this time, there are no other witnesses signed up to testify. Is there anyone else wishing to testify on for or against House Bill 2439? Seeing none, public testimony is closed, and the chair recognizes Representative Themisch to close on House Bill 2439.
Thank you for the opportunity to lay my second bill out. And if there are no other questions, I close.
All right, if there's no objection, House Bill 2439 will be left pending. Is there objection? The chair hears none, and House Bill 2439 is left pending without objection. Members, that concludes today's agenda. If there's any further business for the committee, is there any further business for the committee to address? If not, the chair moves to adjourn. Is there objection? Hearing none, the committee stands adjourned, subject to call of the chair.